Madam, please start.
So, good afternoon, everyone. It's a pleasure to welcome all of you on day 2 of this vital menopause workshop. Before we dive into the crucial topic of today's session, I would like to express my heartfelt gratitude to few key individuals who have made this event possible. My sincere thanks to Dr. Sunita Tandulkar, the president of Foxy, for her unwavering support and leadership advocating women's health. I also extend my appreciation for Dr. Swarna Khadilkar, Secretary General Foxy, whose dedication to our cause continues to inspire us. And she has agreed to be speaker today too. And special thanks to Dr. Parag Binwale sir, the ICUG chair, for guiding in this event with his invaluable expertise. Dr. Sarita Bhalero, Secretary General ICUG, Dr. Sheila Mane, incoming ICUG chairperson, for being such a driving force in the success of this workshop. We are honored to have all the speakers, chairpersons here today. Your commitment to taking time out of your busy schedules to share your knowledge and insights is deeply appreciated. Your contributions are essential to making today's discussion impactful and enriching for all the attendees. As we may move forward for today's session, we focus on an intersection of menopause and non-communicable diseases, with increasing average age of women in India now being 74.13 years. It's much more important than ever for us to address these health challenges faced during menopause. And on this important day, we explore the influence of menopause on metabolic health, cardiovascular conditions, osteoporosis, and critical importance of screening and early intervention. I thank you very much for being a part of this workshop. Let's continue to work together, share some knowledge, empower women with tools and understanding that they need to navigate this life stage with strength and confidence. I look forward to a productive and insightful session today. Looking forward to be there with all of you. Thank you. If I miss somebody's name, I'm thanking everyone from bottom of my heart. So over to you, Madhumita.
Ma'am, we can request for prayer first before starting the session.
Yeah.
Madam, just welcome by Sheila Mane ma'am. Prayer was on first day only. Sheila ma'am had joined. Just take.
Welcome, Dr. Sheila Mane.
Thank you.
Dr. Sheila Mane. Dr. Sheila Mane doesn't require any introduction. I think each and every person.
Yes, we will.
A great academician and a great friend and a great knowledgeable person. Over to you, Dr. Sheila.
Yeah, thank you, Anju. Thank you. And I think yourself, Archana and Raju Nagarkatti, you all have really structured the program in a very well manner. And I welcome all the delegates who have joined for this certification course. And as all of us, we know that midlife is becoming so important with the increasing life expectancy. And Dr. Anju, I would like to congratulate you for your tenure of president of IMS. I know it was very vibrant. And now again, we have none other than Dr. Archana with us for this midlife. And today's program is focusing, I think, on osteoporosis, sarcopenia, and all those things. And none other than, I think, we have an expert like Dr. Niraja is there, Dr. Suvarna Khadilkar, who has done so much of work, and she being the chairperson of a FIGO menopause committee. And I know that she is really into it. And I acknowledge that even in FIGO, that the session for 1 hour on menopause was such a great success there. And we saw so many people attending and questioning. So it was a great session. And now I think we must convey this knowledge to our people. And this society is really creating a very good awareness. And through this certification program, I would like to congratulate Dr. Parag and Dr. Sarita and Dr. Ashok that we are trying to spread the message. So once again, I welcome all the speakers, today's speakers, and excellent topics. Yesterday also we had excellent topics, even pregnancy after 40 is dealt with. Today we have even the discussion on malignancies. So congratulations and best of luck for today's session. And thank you for the opportunity.
Good afternoon, madam.
I think
I
Madhumita,
think
you can take from here.
Nilima, Archana, there is lot of disturbance I feel in the background.
Nilima, mute everybody else except Anju madam and Madhumita for the time being. Madhumita, you can take it from here. Is Madhu there? Okay, no problem. So we can start with the session directly. I think we are very happy that Anju Soni madam and Dr. Rajendra Nagarkatti sir and myself could curate this program well with our three coordinators, Dr. Madhumita, Dr. Reshmi, and Dr. Aditi. So today we have Dr. Madhumita into action. So Madhu, over to you to start the program and the first session. Please call the chair.
Thank you so much,
Archana,
ma'am.
just give me 1 minute. I would like to welcome Dr. Ambuja and Dr. Sudha.
Sure,
Okay,
ma'am. Sure,
so
ma'am.
nice to see amalgamation of people from two societies, and you're also there, and Dr. Niraja. So welcome to this
Thank you.
forum of ICOG. Yeah.
Thank you. Thank you, Chiru.
Sheila ma'am, because I think Anju madam has not left any table unturned. We can see Pushpa Sethi madam also there. So thank you, ma'am.
Yeah, Pushpa Sethi madam
so
also. Yes.
So let's begin, ma'am. Thank you, Sheila ma'am. Thank you so much.
Thank you so much, ma'am. So moving on to the first session, it is my honor to invite the chairpersons for this first session, Dr. Sumati Anand ma'am, Dr. Meenakshi Ahuja ma'am, who's the president of Delhi Menopause Society and also the academic secretary of Delhi Gynec Forum, Dr. Sujata Dalvi ma'am, who's now the editor-in-chief of Jogi and also the secretary of Mumbai Obstetric and Gynecological Society, Dr. Jignesh Shah, who's the past president of Indian Menopause Society and also the current vice president of ISOPAR. And for our first speaker, we have our eminent Dr. Neerja Chawla, who is the vice president of Foxy Northern Region and also the founder chairperson of Digital Education Committee of Indian Menopause Society and patron and founder president of Menopause Society region of Chandigarh. Over to you, ma'am. Neerja, ma'am?
Yeah, you have to make
Yes,
me host.
Yes,
no?
yes, ma'am. Nilima, can you make ma'am host?
Yes, already done, man. Just open your presentation.
Just share the slides, yes, ma'am.
That share button is not visible. Share my presentation.
It should be at the bottom or top of your screen.
I think madam can log out and relog because sometimes it happens. So you shared priorly, ma'am.
Nija, is it not on the bottom of your screen?
I found it. Yeah. So I'm starting my presentation. Thank you all for inviting me and all those who are present here. So we are here for the pathophysiology of osteoporosis, and you will all understand why to do this. We first have to know about the normal biology. So the bone, in addition to its classical roles of locomotion, protection of internal organs, regulation of mineral homeostasis and storage of calcium, and hematopoiesis in the marrow, it also contributes, which will sound very strange, but to the regulation of glucose metabolism and energy expenditure, influences male fertility, and even impacts cognition. This is because of the secretion of the osteocalcin by osteoblasts, which undergoes decarboxylation in the acidic environment of resorption. This gets absorbed and then leads to systemic hormonal effects. So to do all these diverse functions, what the bone needs to do is modeling and remodeling by continuous cycles of both. But there is a difference between these two processes. In modeling, it is either the resorption of bone or the formation of bone. This is not coupled to each other. It acts independently at different sites, leads to changes in the dimensions and shape of the bone, usually seen from birth to adult, and is an adaptation of the bone to the altering mechanical demands. Remodeling, on the other hand, is a concomitant resorption and formation of bone at a particular distinct site, responsible for the maintenance of skeletal integrity, and it renews the old and damaged bone. So we can see that if there is an impaired or an increased remodeling, then the resorption becomes more than the formation, and this is the fundamental pathophysiological mechanism which leads to osteoporosis. As far as the nature of the bone is concerned, it consists of osteoid, which is collagen, non-collagenous proteins, and the crystalline complexes of calcium and phosphate. The calcified bone contains 70% of inorganic material. The types of bone will depend on the pattern of the collagen. For example, the woven bone is weak because the collagen is in a haphazard organization, but it is found when in the fetus and adults whenever there's a new fracture. Laminar bone, on the other hand, has regular parallel alignment of the collagen in sheets. This is very strong. And remodeling replaces the woven bone with a lamellar bone. And in almost all adults, the bone there is lamellar. So now let's go to the key cellular components, which are the bone cells, which are of 4 basic types. The osteoclasts, they act by bone resorbing by acid and proteolytic enzymes, and they are derived from a hematopoietic lineage. The osteoblasts, on the other hand, form the bone. They cause synthesis and mineralization with a poorly characterized mechanism. These have a totally different lineage, and they are derived from the mesenchymal stem cells. The osteocytes are the most abundant of the bone cells. They are former osteoblasts trapped in the matrix, and they were supposed to be very unimportant, non-participating bone cells. But we now know that they are very important for homeostasis, for bone formation, as well as prevention of bone formation. And they have a mechanico-sensory function by various signaling molecules. They also connect the osteoclasts, the osteoblasts, the surface of the bone, and the vasculature by various canaliculi. Then the 4th type of cell is the bone lining cells, which are osteoblasts, which are not being remodeled. There's a lot of crosstalk between all these bone cells. In the bone remodeling cycle, this continuously happens, several cycles of this throughout the life, so that an adult bone is replaced every 10 years. This has 5 phases, and the first is the activation phase, where the precursor of the osteoclasts are stimulated and converted to mature osteoclasts, which cause bone resorption. And this is an important step for signaling the bone formation. In the reversal or end of resorption phase, this is the 3rd phase, the osteoblasts and the osteoclasts are there together, but the osteoblasts, they will induce an apoptosis of the osteoclasts, and then the osteoblasts will go on towards bone formation. In the termination phase, both the osteoclastogenesis and osteoblastogenesis has become equal, and the osteoblasts now become resting bone cells on the surface of the bone. Traditionally, we have talked about traditional pathophysiology, in which what they have done is they think of hormones as very, very vital for the regulation of the bone modeling. In this, estrogen is very important, and testosterone, either directly or indirectly through estrogen, and parathyroid hormones. These are the few hormones which are talked about in traditional pathophysiology, which also talks about deficient calcium intake, vitamin D deficiency as the basics of the thinking or the models about pathophysiology. Now, a little bit about estrogen. It acts by its direct action and through receptors, as well as for various proteins and signaling molecules. In menopause, when there is an estrogen deficiency, osteoclastogenesis becomes more than the blastogenesis. There is bone resorption and risk of fractures. Osteoclastogenic cytokines predominate. With advancing age, the formation takes longer than the resorption. Therefore, there is a negative bone balance. Women are more at risk because smaller skeleton, greater architectural damage. So we have seen that the pathophysiology of osteoporosis is multifactorial. We have seen the traditional, but we know that this limiting ourselves to a unilateral hormonal base is not correct. There are several pathophysiologies proposed, but before that, we must do the rank-rankle OPG pathway. The rank are the surface, they are receptors on the surface of the osteoclasts. Rankle, which is the ligand, it is produced by the osteoblasts. It activates rank to form mature osteocytes, which lead to resorption. And osteoperidine will be released by the osteoblasts. They act like a decoy receptor and they bind this complex, increasing formation. So this balance of rankle and OPG is very, very critical. Now, talking about the proposed pathophysiology, we now have osteoimmunology, where the osteocytes are considered as a prototype of the osteoimmune cell. Both these two types of cells have common precursors, and interactions between the immune cells and the osteocytes has been found with bone destruction and inflammation in several conditions. The CD4 cells, which are found in rheumatoid arthritis, causes inflammation as well as bone resorption. The second way is having a lot of common molecules, signaling factors. In post-veno osteoporosis, it has been found that inflammatory cytokines are much more compared to non-osteoporotic postmenopausal women. And osteoclastogenesis fuels the inflammatory cytokines. The second is the gut microbiota. We know that it influences the GI tract, but it also has very complex relationships with other disorders. It also influences the bone by influencing the absorption of nutrients by changing the pH, and also through the short chain fatty acids, which is a very key regulator of bone homeostasis. And when microbial fermentation of dietary fibers gives rise to SCFA, then it helps in bone homeostasis. Therefore, such prebiotic diets are very useful. Here we talk of the gut skeletal axis. Then there is a gut immune bone axis, in which bone active cytokines are released in the gut, immune cells are activated in the gut, and they travel to the bone. The last is the cellular senescence, which is irreversible cell cycle arrest and resistance to apoptosis. And this is induced by stress, and its number increases in aging, characterized by production of pro-inflammatory cytokines and several proteins which degrade the matrix. This state is known as senescence-associated secretory phenotype and linked to age-related dysfunction and diseases. In osteoporosis, there are many cells which become senescent. When you eliminate these, it has known to prevent age-related bone loss in mice. So this is an overview of the proposed pathophysiology: impaired immune functions, gut microbiome, accumulation of senescent cells, which all act to disbalanced bone resorption and osteoporosis. Now there is another thing which is a genetic complement. The bone mineral density is a heritable trait. 144 genes are linked to it. Dysregulation of the Wnt pathway as well as several genes are known to cause changes in the extracellular matrix and early onset osteoporosis. So finally, bone remodeling is increased, or when it is impaired. Whenever either of these two, it will result in osteoporosis, which is a metabolic disorder. Osteoclastic bone resorption not compensated by osteoblastic bone formation is the crux of it. Traditional pathophysiology has focused on hormones, deficiency states, and secondary hyperparathyroidism in menopausal states because of deficiency of estrogen. But newer insights are available. The immune system, gut microbiome, cellular senescence, which all contribute to the pathophysiology of osteoporosis. And then we have the genetic basis of osteoporosis. Therefore, I say that understanding pathophysiology is key to the prevention and treatment of osteoporosis. Thank you.
Over to chairpersons for their. Dr. Sudha, will you take over? Dr. Sudha?
Sudha ma'am, Sudha Sharma ma'am. Rajendra Nagarkatti sir is also there.
I cannot. Oh, yes, yes.
Yes.
So, am I the chairperson for this?
Yes.
But beautifully done, Dr. Neerja. You know, you have done it so in depth. I tell you, we have also done pathophysiology, but I think you have really gone into the mitochondria and into the genesis of it. Beautifully done. And I hope everybody has, taken good message from here. And everybody now knows, what is the woven bone and what is the trabecular and what is the solid bone, and why the fractures are, more common on those trabecular bones and why the fractures are less common on the shaft ones. So congratulations and thank you.
Thank you so much, ma'am.
Thank you.
Yes, ma'am. Thank you, ma'am. So at the end of the first wonderful talk, now we move on to the.
Madhumita, I would like to
yes.
welcome Dr. Ratnabali also. She's just joined. Welcome, Dr. Ratnabali. And thank you. Yeah. So over to you, ma'am.
Yes, ma'am. So now moving on to the second talk by our very own Dr. Anju Soni ma'am. Ma'am needs no introduction. She's Vice President of FOXY 2026 and also the current President of IMS, and she was also the Vice President of Endometriosis Society, Vice President of Endometriosis Society of India and the Governing Council member of ICOG. Over to you, ma'am.
Okay. Yeah, let's not waste time. Time is very.
Yes.
Yeah. So, can I share my screen?
Yes, ma'am. Sure, ma'am.
Is my screen seen?
Yes, ma'am. Opening.
Yes, ma'am. Yes, ma'am.
In presentation mode?
Yes, ma'am. Yes, ma'am.
So today I'm going to talk about one very, topic which is very, very important, I feel, to each and every woman who lives in our country. And this topic is very dear to my heart. So I want to talk about this, especially discussing where to screen and how to screen. And I would like to thank Dr. Neerja for making my work so simpler. Thank you, Dr. Neerja.
Thank you.
Your penmanship has given a good, roll on for my ball. So whenever we talk of osteoporosis is as a third threat, particularly attributable to women physiology, we all know. And as the Camilla Parker said, that osteoporosis is not an inevitable part of aging. It is preventable. So it is vital that all of us at all ages start talking and take care of our bones before it is too late. So whenever we talk of risk management, it is very important to know that osteoporosis is a silent threat. And one second, just give me 1 second. Osteoporosis is a silent threat and it can impact significantly. And in a highly populated country like India, screening is very important for women. And every woman cannot be screened, and it is crucial to prioritize the identification of high-risk individuals by focusing on prioritization, as we can assess probability of osteoporosis and evaluate risk through strategic assessment and diverse plan to treat and control, aiming to reduce the cost and impact the fractures. Effective management involves monitoring these at-risk women and population, providing them timely solution and prevent complication. Through targeted evolution and strategic action, we can ensure better resource utilization and long-term benefits for the woman. So we all know that the prevention of osteoporosis starts right in utero. And children of the mothers who had a higher frequency of intake of calcium-rich foods during the pregnancy had higher total spine bone mineral content and BMD. Children of mothers with higher folate status at 28 weeks of gestation had a higher total spine BMD independent of parental size and DEXA measurement. We all know that WHO defines osteoporosis as a systemic, please quiet, systemic skeletal disease characterized by low bone mass and microarchitecture deterioration of the bone tissue with consequent increase in bone fragility and susceptibility to fracture involving wrist, spine, hip, rib, and humerus. So we all know that it's a major public health problem among the several changes faced by growing elderly population with increasing longevity. The global data says that 20% of the women die within 1 year of fractures and 50% will never regain functional independence. The vertical fractures have a significant mortality and they have a long-term morbidity. Now, there are two types of, pathogenic mechanisms which affect the trabecular bone. I just to reiterate, the type 1 which affects mainly the trabecular bone occurring in a early part of menopause transition, accelerated bone loss at the rate of 1 to 2% per year, and later 1 to 5% due to declining estrogen level, and it's seen in 5 to 7 years of menopause. Type 2, which is senile osteoporosis, is related to the age, and the bone loss occurs at the rate of 1% per year in both sexes and affects cortical as well as the trabecular bone. Now, when we talk of the secondary of osteoporosis, which is because of the use of chronic glucocorticoids, rheumatoid arthritis, collagen vascular disease, inflammatory bowel disease, hypogonadism, thyroid dysfunction, type 2 diabetes, and use of erythroid inhibitors in the breast cancer survivors. So when we look at the prevalence increases as the age increases. This is very important. So we must know what are the risk factors. We all know that there are some non-modifiable factors like advancing age, female gender, Asians have white more than Asian, low peak bone mass, family history, personal history, and low BMI. Then we coming to the modifiable risk factors: smoking, in calcium and vitamin D intake, low BMI, estrogen deficiency, and hypogonadism and chronic glucocorticoid therapy effect. Now, what are the symptoms? We all know that osteoporosis is a silent disease. The bone is lost without symptoms. Women presenting with fragility features, they complain of severe pain. There can be sudden onset of minimal trauma. There is a chronic pain localized to mid-back, which may radiate to the front of the abdomen. The commoner sites are hip, spine, and forearm. Other sites could be pelvis, proximal femur, or humerus, or tibia. It is so. Now coming to the Indian guidelines, should we do a universal screening or targeted? Let's come to that point. Early diagnosis in asymptomatic period is the most essential part, and for that we need, so that we can timely do the management which is associated with morbidity as well as the mortality. The osteoporotic risk factors on a large scale, the group whole population cannot be cost effective in our population, and then more selective approaches that is the targeted and screening disease detection are advocated. Now, the evidence says that FRAX India 2008, which has been, which had a moderate predictive value and Indian cutoff proposed at 2021 and 2025 model shows that it has the cost effectiveness, and use of FRAX India as a screening tool combined with the clinical judgment and DEXA is very feasible. But we still lack national fracture incidence and mortality database. So we need to work more on that. And when we talk of the globe, in systemic review, they are having different moderate discrimination in all the other countries. And in 2024 and 2025, countries still are continuing to set their local goals for assessment and intervention using the FRAX initiative. Now, as per the the STF, that is USA recommendation, the DEXA screening for all women more than 65 years is a recommendation. And all the meta-analysis clearly shows that the early detection and treatment reduces the fragility fractures in a very big rate. And the cross-sectional study shows that the risk of tools like ostea and other tools show only a moderate accuracy for other, hip or spine fractures. So the real world data shows that only 16 to 20% of very high risk patients receive proper therapy and men remain untreated. So now they have started using AI models where machine learning will help us to have more accuracy and more predictive value per se. So let's come to the debate on universal targeting or whether we should do a targeted targeting. So what we should do is that we should look for the clinical risk factors as per the PM of India, where uh, advancing age, low BMI, prior history of fracture, parental history of fracture, smoking, alcohol, and use of glucocorticoid and arthritis have to be screened early. And we also need to look for the environmental factors like nutrition, physical activity, sunlight exposure, and risk of falling. This is a very beautiful table which talks about the how we basically screen the patient, and we must start encouraging basic bone health for the women when they are beyond 30. So promote bone health beyond by giving them calcium, vitamin D, and exercise. And 50 to 64 test BMD women for fragility fractures and corticosteroid use and osteoporosis. And at 65, all eligible women for testing with extra risk factor. And if the risk factor is low, then less than 10%, we reassess in 5 years, moderate risk, perform X-rays, high risk for more than, then give them pharmacotherapy. It is important to know about this flow chart so that we can prioritize screening based on the age, risk factors, and ensure early detection, appropriate intervention, enable targeted testing, reducing unnecessary screening, and improving patient outcome by focusing on those most at the risk. So, as this, I have already said that we need to screen. US FDA talks about universal screening, which we are not recommending. So osteoporosis, OSTA screening is simple, cost effective, and it tells us about the low, moderate, and high risk. So we know what, based on the score on age, race, rheumatoid arthritis, history of non-rheumatic fractures, and over 50 or 45 years of age, estrogen use and weight, all this will add to the score. We have our own Indian Fraxa tool, which is available online, and this is has until now we have collected. Indian Menopause Society has collected data which is available for prevention of osteoporotic fractures and mortality rate, and it may not serve true to for the uses of some other people, but it is really helpful for us. So what do we do about the other tests? We must do a CBC, ASR, random sugar, calcium, creatinine, and albumin, preferably fasting serum phosphorus, alkaline phosphatase, serum TSH, vitamin D, if possible, X-ray out thoracolumbar spine, and PATH based on the clinical judgment. Now, the indication for DEXA it's a gold standard. And when we get a patient 5 years beyond the natural age of menopause or less than 5 years since the menopause with more than one, more than one or two clinical risk factors, then we must do DEXA because especially in the case of women who are early age of menopause, natural menopause, that is less than 46.7 years, and life expectancy of Indian women, we have just told you, the accrual of peak bone mass is low. The early age of presentation of fracture with accelerated bone loss in immediate 5 years of menopause. Stratification of age shows the prevalence of low bone mass in more than 40% of the age and increases to more than 80% by the age of 60 years. DEXA is a, there is some kind of music. Can you please control? The indication for DEXA are that all postmenopausal women beyond 5 years, postmenopausal women less than 5 years of menopause with risk factors, radiological evidence of osteopenia, presence of vertebral compression, women with fragility fractures. We need to initiate pharmacotherapy before initiating pharmacotherapy also, and emerging indication are to measure the total body mass and lead tissue also. So we know that BMD or DEXA is a gold standard method. It uses T and Z scores, and this is a grade A evidence. And it may peripheral DEXA done at OPD level. It may be used for mass screening, but it has a high negative predictive value. We all know that normal T-score is -1. If we go -1 to 2.5, it is penia. If we go beyond -2.5, it is osteoporosis. And a T-score below -2.5 with fragility factors is known as severe osteoporosis. What about the bone turnover markers? Now, there are two types of bone markers, bone resorption and bone formation. The bone resorption, like serum C terminal telepeptide and the serum procalcitonin bone formation markers, these are done on the patient to monitor the, the treatment which you are giving to these patients. But they are not done routinely. That is the very important point. I want everybody to take home this message. So to conclude, osteoporosis is preventable and manageable with awareness and timely care. We need to build bone mass early through early habits, identify high-risk groups like postmenopausal women, elderly, on steroids, low body weight, family history. We need to use preventive therapies for high-risk women, ensure good intake of calcium, vitamin D, and of course, exercise and good nutrition is again very, very important. We need to screen women early. I'll just take 1 second. Screen early during menopause to prevent bone loss, promote awareness, self-care for a stronger and healthier woman. Step up bone health, step your way for a stronger bones. Take care of your bones and prevent osteoporosis before it is too late. Thank you very much.
Thank you so much for the wonderful talk, ma'am. Nirja ma'am, can you give your comments, ma'am?
You're muted, Nirja.
You're muted, ma'am. Nirja ma'am, you're muted, ma'am. You're still muted, ma'am. Nirja ma'am, you're muted.
You're muted. Yeah.
Yes, ma'am.
That was from the host. I thought that was a lovely lecture, and I think you covered it very well. And I'm very happy about the FRAX coming for India, because many years ago we used to say that it's not available for India, so we used to follow the Singapore model. Now the Singapore model, actually it's a blue zone. So if we know about blue zones, that is the 6th blue zone of the entire world, where people naturally live more than 100 years of age. So to compare our women and population to Singapore was absolutely not right. So thank you for bringing all this to us and telling us about the tracks available for India. I think it was very well done. Thank you.
Thank you so much, ma'am. Anju ma'am, Parag sir and Sarita ma'am, they're here, ma'am.
Hi, Dr. Parag, welcome. We are very happy to see you.
Yeah, thank you. And, I'm not going to say much, but thank you, all my friends. Today, I think there's a majority of speakers from the Indian Menopause Society. So I welcome you all on behalf of ICOG. And of course, all of you are fellows of ICOG. So it's wonderful to see you all. Welcome, Ratnabali. I'm seeing you for the first time in the ICOG program. Of course, thank you, Nirja and Anju. Both your presentations were really good. And I'm looking forward to some great learning experience today. Thank you, and let's continue with the program.
Dr. Pushpa, Dr. Sudha, Dr.
I know
Swarna.
Ambuja. I can see all friends from Indian Menopause Society today.
Thank you.
They are
Dr.
the star speakers for these topics.
Yes, and of course, you can't forget Suvarna,
Yeah, Dr. Swarna, I
with
said
whom
पहले
I have
से
a special bond in the
नहीं
Indian
Dr.
Menopause
Swarna का तो मैंने
Society.
सबसे पहले नाम ले दिया.
Thank you, Suvarna, for being here today as well.
Thank you for inviting me.
Moving on to our third talk, we have none other than Professor Suvarna Kadilkar ma'am, who is Secretary General of FOXY and also the President of Mumbai Obstetric and Gynecological Society and the Editor Emeritus of Joggy India. And she was also the past President of Indian Menopause Society. Welcome you, ma'am, and over to you.
Thank you so much. I'll just quickly see my presentation.
Yes, ma'am.
I just came to know I have 15 minutes only, so it's a difficult task, but I will finish on time, hopefully. Can I share? Yeah.
Yes, ma'am.
Is the screen visible?
We're not able to see a slide, ma'am.
Okay.
Yes, ma'am. Now it's starting to show. Yes, ma'am. Screen is. We're able to see a screen.
Can you see now in
Yes,
this
ma'am.
screen, this
Yes, ma'am.
slideshow mode?
Yes, ma'am.
Yeah, okay, thank you. So to begin with, I once again thank Parag, Sarita, and I was so excited to see all our Indian Menopause Society members on here, this forum. I can see Sudha, Nirja, Anju, and so many of us, and then Ratnabali, yes, all of you. I'm very happy to again be with you all. And I think this talk I have given several times on sarcopenia. And since last 10 years, I'm giving this talk. But when I was searching for the latest evidence, there is nothing much has, come through, which is very robust and which we can really put in practice. Majority of the things on sarcopenia are, yes, in future we may get this, in future we may get this, since 10 years, but still it has not been freely available to us. So I'll just quickly run you through various slides that I've prepared on sarcopenia, bone health, and frailty. So in 2011 census statement of India, the total population was 1.21 billion, and we can imagine women, half of them, 48.46% were women. And I think the next census will give us more detailed analysis of what our women percentage would be, because it is falling, even though I don't know what will be the above 50 age. You can see 10% above 50 years were more than, among in year 2000, then 22% above 50 years. We expect this year, 2025, we'll come to know only after the census report is out.
33% above 50 years in 2050. So with growing elderly population, with increasing longevity in India, postmenopausal musculoskeletal disorder is emerging as one of the major public health issues, and it is high time that our government takes a note of it and really has some policies at the center to implement across the country for middle-aged and geriatric population. Now, what is sarcopenia? I tell you my experience when I first started speaking on it. Even many learned people would come and ask me what is sarcopenia, and they would pronounce it as sacropenia, as in P-A-I-N-I-A. So then sacropenia, that means they used to think there is a pain in the sacral area, and the terminology was absolutely new. Now we have been talking about this terminology several years, and it is a progressive loss of skeletal muscle mass, strength and function, and it has been recognized as a major contributor to frailty, falls, and reduced independence and mortality amongst older adults. So, as global populations age, understanding and managing of the intersection between menopause. Now, why we gynecologists, why we menopause specialists are talking about sarcopenia? Because there is a clear relation of menopause and sarcopenia, and it is high time that we take it as a priority for public health and clinical medicine. So various musculoskeletal disorders that women beyond midlife they face are of the bone and the muscles and of the cartilage. So there are three various connective tissues which get affected because of the deficiency of estrogen around menopause or low levels of estrogen at and beyond menopause. So osteoporosis is something which I think Anju has very in detail, exhaustive presentation she has covered. Then osteoarthritis, where the joint cartilage gets affected. And last but not the least, it is the muscle mass and muscle strength, which all three put together, what is the impact on the women? It is the frailty, the falls, fractures, and I'm very sorry to say if this is not prevented, many women may have the after effect of fractures and falls, that they will have early death and higher mortality. So we want to prevent that. And this is how the normal muscle looks, and this is how the atrophied muscle looks. And this is the type 1 and type 2 fibers of the skeletal muscle, and this is a normal muscle tone, what you can see here, and the other side you can see the sarcopenic muscle, and it is because of all these factors which are written, the mitochondrial dysfunction which is linked to deficiency of estrogen, loss of type 2 fibers, and there is an imbalance in protein metabolism. So what is the clear-cut definition? We just described loss of muscle mass and function associated with aging. So don't mix up with cachexia. Cachexia is defined as weight loss due to an underlying illness. So a young person can also get cachexic, but sarcopenia essentially is beyond middle age and geriatric population. It is a sole factor aging, and now we understood that it is also beyond menopause in women due to loss of or decreased estrogen levels. So there are certain other definitions that we must know: osteoporosis, myosteatosis, obesity, and frailty, which we will soon describe and we will know what they are. But the operational definition of sarcopenia can either be based on the measurement of muscle mass alone or combining all the three performances together. And the consensus definition that was defined by European Working Group of appendicular skeletal muscle mass index, that is ASMI, of less than 5.5 kg per meter square, that is universally accepted. Now, what are the various, they have suggested a conceptual staging as pre-sarcopenia, sarcopenia, and severe sarcopenia. So you can see how they progress with the deteriorating function in increasing degree, and that is very important because we should know support design of the research studies when there is a specific grading of sarcopenia. and we can choose the treatment accordingly. So we have done one imaging this thing for the sarcopenic individual. On the right, you can see that is a 86-year-old sarcopenic individual, and here it is a normal. If you compare, look at the loss of muscle. And what actually happens in the muscle in the sarcopenia, it is characterized by atrophy of type 2 muscle fiber. And there are two fibers, type 1 oxidative type fibers, and there are type 2 fibers. Type 1 has higher content of satellite cells than the type 2 fibers, and they benefit from more significant blood and capillary contribution. Now, under further understanding of sarcopenia, you can see what are the various complex interdependent pathophysiological mechanisms. You can see in this pictorial diagram various physical inactivity, aging, resistance to, postprandial anabolism, insulin resistance, endocrine factors, inflammation, lipotoxicity, mitochondrial dysfunction, all put together will lead to hasten up the process of muscle atrophy. And these are the, again, pathophysiological mechanisms where actually neurodegenerative processes decrease protein synthesis. And genetic influence is also there. Not that all women after menopause will get sarcopenia. And this is the clear diagram as a balancing of protein synthesis and protein degradation. So there is an anabolism and catabolism. You can see the factors on the left, which are slightly gray, and the most important factor is the mTOR, which brings about the protein synthesis and it builds protein and muscle, whereas myostatin is the important factor here, which causes atrophy, and it affects the atrophy related genes and causes protein degradation and muscle mass. So what does the estrogen deficiency do? It causes increase in inflammation, visceral adiposity is increased, and it brings about even intramuscular deposition of fat, that is myosteatosis, muscle strength is decreased, mass is decreased, and the satellite cells, that are the stem cells in the muscles, which which estrogen usually causes increase and of synthesis of various muscle fibers, whereas this causes deficiency causes decrease in the satellite cells proliferation. So all put together, and along with that, bone density is decreased. So rather, the osteoporosis and sarcopenia are both the conditions which occur simultaneously, maybe one ahead of others, and therefore it is important to grade each of them. Now, there are other hormones apart from estrogen which cause this help in, not help, but they cause deterioration of muscle health. And that is the most important is the testosterone, which also we have found that it declines, even though the ratio of estrogen to testosterone is in favor of testosterone, the total testosterone declines after menopause, and it contributes to loss of muscle mass, strength, and here the overweight women will have a higher residual levels, so that is a little benefit there. Cortisol is typically increases with age and stimulates the muscle catabolism, contributing to sarcopenia. Especially the early morning cortisol levels will help in bringing out the amino acids from the muscle, and it will cause the process in the liver to increase the blood sugar levels. Now, what are the various emerging biomarkers? Just as I said, they are not yet available. They are emerging since many years, but there, I think, looks like it will come in future, near future. So there is a creatinine to cystatin C ratio. Lower levels of these marker will lead to, is associated with sarcopenia. The CaF22 levels, if higher the levels, they will cause predictive of neuromuscular junction degradation and sarcopenia. And other two, microRNAs coming in a big way for in other endocrine abnormalities as well. And this miRNAs have been implicated in skeletal muscle apoptosis during menopause. So emerging diagnostic tools, I think we have already talked about the European Working Group on sarcopenia in older people. And we have Asian Working Group, which they have similar group, three-pronged approach, but they say that we have to use, I think I just saw that we have a India specific FRAC score level, so that it is the local, the regional cutoffs that you should use for muscle mass and strength, because I'm sure all of you have seen that there are different people across Asia and other regions. So we must follow the regional cutoffs. SARC-F is a very simple 5-question self-reporting tool that assesses daily activities, and that is this is the SARC-F tool. It has 5 components: strength, assistance with walking, rise from chair, climb stairs, falls, and the scores range from 0 to 10, with 0 to 2 points for each component. A score equal to or greater than 4 is predictive of sarcopenia and poor outcome. So who should be screened? So all these people who are bedbound, non-ambulatory, person who are more than 65 years, those who have reported weight loss without any reason, more than 5%, noted or reported decline in function, history of recurrent falls after hospitalization, and various comorbidities like diabetes, congestive heart failure, kidney disease, and especially when you measure the gait speed, if you find a woman is walking slowly, less than 0.8 meter per second over 4 minutes, then it is suspected that you should screen her for sarcopenia. These are the various diagnostic tests: muscle mass anthropometry, bioimpedance analysis, DEXA, which is the gold standard, easily accessible. For osteoporosis, awareness has been increased. We do DEXA for that. Many centers are available across the country, though not in rural area, but there are many places where DEXA is accessible in nearby centers. So we can do DEXA, which will give you the exact exact reading, and they will suggest whether the muscles are sarcopenic. Now, predicted skeletal muscle mass, you can say skeletal muscle index is calculated in women if a normal muscle is to be said when this index is more than 6.76 kg per meter square. If it is less than that, in women it is moderate, and less than 5.75, it is a severe sarcopenia. Now, these are the various diagnostic criteria. I'm not going to go into the details of it, but get up and go test for 10 more than 10 seconds. This is a very nice, easy, simple test you can do. Short physical performance battery, that's a very nice test you can do, and DEXA happens to be a gold standard. Now, what are the consequences of sarcopenia? The physical function gets impaired. There is a loss of function, disability, frailty, and frailty increases disability due to higher risk of falls, hospitalization, institutionalization, and very sadly, increased deaths. Now, what is the global burden? Let us look at frailty, global burden of frailty. Let us see here. Look at the country and the prevalence rate. If you can see, the highest rate here is Germany. So prevalence is very high. I'm very surprised it is such an advanced and high income country where nutrition no problem, exercise no problem. But these are the older studies and older reports. We may get some future some data. And here, if you see the age wise, as the age increases, you can see how the prevalence of frailty and sarcopenia goes on increasing. Multitude and 85 and plus, it is 33%. What is the Indian scenario? We have really not much of data in India, but prevalence therefore is very wide, 5 to 70%. And we can see among older hospitalized patients, the females of 28.1% females were frail. And what do you mean by frailty? Frailty is any 3 of the 5 criteria are there. You define that the woman is frail. I think at the spot diagnosis, when you look at a woman, we many times say, oh, she's become so frail. But what does it mean? Actually have become frail? Just put it in these 5 criteria. If 3 are positive, yes, she is frail. So unintentional weight loss, physical exhaustion, and things like that. So I have put a slide of osteoporosis just to tell you all that they both work together. It's a bone muscle, unit, that there are myokines, there are cytokines, they bring about crosstalk, and therefore this is how we do for bone assessment. We have Frax tool. For sarcopenia, we have Sarkif's tool, and for frailty, we have a frail tool, that is fatigue, resistance, ambulation, illness, and loss of weight. So it's very easy to remember all 3 connective tissues together. We can assess and diagnose this. So what is this sarcoosteoporosis? It is estrogen receptors are found in both tissues. So we should diagnose, as a sarcoosteoporosis at early stages of menopause transition between ages of 45 to 55. We can predict, and therefore preservation of bone muscle mass and strength can happen. So are there 3 players? We have bone, we have muscle. Now the third one is the adipose tissue and cartilage. So high incidence of morbidity and mortality when sarcopenia is associated with obesity, because it comes with all the metabolic problems and comorbidities. So there is a possibility of increased, increase in the mortality and morbidity with sarcopenia. Now, this is the health risk in the diabetes on musculoskeletal system. So both type 2 and type 1, they have affectation on the bone mineral density. But in type 2 diabetes, it is said that it is not that low as compared to type 1. But in patients who are type 2 diabetes, maybe they have high BMI, so it may be little bit helping them to maintain certain bone and muscle strength. So in Women's Health Initiative observational study, postmenopausal women, they found that type 2 diabetes participants have a 20% increase in the risk of fracture compared to those without type 2 diabetes. So diabetes as such is a high risk, but between type 1 and type 2, type 1 is at a higher risk of developing fracture and sarcopenia. So diabetes and loss of muscle mass share common etiological pathways. Reduced physical activity, lower activity of anabolic hormones like insulin-like growth factor, testosterone and ghrelin, and there is a negative effects of diabetes on blood flow to muscle cells. So how do you treat these women? So the mainstay of treatment of sarcopenia is resistance training and exercise, nutrition, lifestyle modification, prevention of falls. I think we have been talking about this time and again. Whenever we talk about any aspect of menopause, we have these 3 always listed in the management, but more so in sarcopenia, because the resistance training that is important to build the muscle. So nutritional supplements if her diet is not good, and certain medical therapies may come up. Now, for exercise, the evidence is very strong. It is the primary intervention, progressive resistance training 2 to 3 times a week for 8 to 12 weeks, improve muscle strength as well as functional measures of physical performance, including gait speed, has been noted. Now, these are the various ways you can these are the strengthening exercises, aerobic conditioning, and the range of motion goes on improving as the more and more daily practice of these activities follow. Now, what about nutrition? All these are well known. I'm not going to talk much about it. Vitamin D, calcium, I think Anju has already covered, but little bit I will talk on proteins and other nutrients. So I will skip the vitamin D and this. Now look at the slide on proteins. So in addition to calcium, this protein is important for providing the structural matrix of bone. It optimizes IGF-1 levels, and it is reported to increase the urinary calcium, and it is reported to increase the intestinal calcium absorption. If you see WHI trial reanalysis, it has shown 20% increase in protein intake causes 12% lower risk of frailty and sarcopenia. So high protein intake. It is the level of 1.0 to 1.2 gram per kg body weight per day is most probably optimal for older adults. Now, magnesium is important, zinc is important, and copper is important. If they are minor elements, they are talked less, but they are very important. Magnesium, bone forming mineral. Copper slows down the activity of both osteoblast and class, helps build bone. Therefore, it is vital to get a perfect balance between copper and zinc, as too much of one can affect the work of other. Zinc required for deficiency contributes to poor bone status. So, reports show that a combined supplement of calcium, zinc, manganese, copper produced led to an increase in the BMD in a small study of postmenopausal women. So I think we must do. I'm going to skip vitamin D. I think Anju, you have covered vitamin D. So certain medical therapies like anabolic medications, if there is no much of with all these lifestyle modification, diet, exercise doesn't help, then anabolic medications can be used. What is called as SAMs, that is selective androgen receptor modulators, can be given selectively under monitoring, because it is ultimately, it is like SAMs, but requires then growth hormone. Myostatin inhibition causing monoclonal antibody is coming up now. Maybe it will be available, but I don't know when. Again, metformin, angiotensin converting enzyme inhibitors, all these are in the pipeline. It is a matter of future research, but let us hope that they will come up for easily available for us for treatment. And there was just awareness, we did the not we, this Patil and Sapna Patil has reported in Malaysian journal. I really got very much impressed with that. Look at only 20% of patients, they get information from doctors. So what are we doing as doctors? Are we not making our postmenopausal women aware that such a thing can happen? So media 55%, friends 20%, newspaper 20%, and only 20% from doctors. So it's a clear need to increase doctor participation. So I think that is what I want to see. This is the further reading for these are the three main sources. You can go, these are the latest articles which you can go through it and you'll learn more about this. And can I request all of you to please scan this survey, at the FIGO level. I have presented this, and we have started this, my committee of menopause age, women at menopausal age. We have done this FIGO level survey. It is still active. So may I all of you please open your cameras and scan this. You will get the same survey on your Google, and please fill it. It will take 5 minutes. So copy the scan code so that you can do it later also. Take a picture and you can then scan it. And please, my sincere request for a better, understanding of how people are managing menopause across the globe. I think we are started this initiative. Please help me do this. Thank you so much. Did I take a lot of time?
So much. Thank you so much for that wonderful, clear talk, ma'am. Anju, ma'am, your comments, ma'am?
Yeah, I think my thinking about her even when she was not in India was the most right decision I took. She said, no, मैं कैसे करूँगी? मैंने कहा आपको तो आना ही है. Thank you, Swarna, for giving such a beautiful insight. I've heard you so many
calling me when I was in South Africa.
So, but this is a topic least discussed. So I think it must be a great for everybody to have the insight on this very, very crucial topic, which, we think कि हमारे जो, the elderly people in our house, like my own mother only, Sudha would also vouch for that, they look very frail and they look very thin, and, they are the people who are suffering from this disease. So please do not ignore your own family members and look into this problem. This is the most important thing which all
Before
of us.
family members, I will say, you look at yourself. Many a times I want to get up from the chair. I find difficulty. So look at yourself also after a certain age. please do the resistance training so that you maintain your muscle health.
Yes, that's the most important thing. The muscle and health is very important, even to keep the bone health good.
Yes.
Yeah.
Yes.
It's one unit. The bone muscle crosstalk continues to happen. So it's a one single unit. So you have to maintain both together.
Absolutely, absolutely. Thank you, Dr. Sharna, for being here. Thank you very much. Over to you, Madhvita dear.
Yes, ma'am. So at the end of 4 wonderful talks, now we move on to our second session. And for that, I invite our chairpersons. Nilima, can I have the slides, please?
Dr. Madhulika, you still have one talk in this session. Yes.
Ma'am?
This is the second session.
Yes.
This is the same
No, ma'am,
session.
yes, ma'am. After the talk, yes, ma'am. You also talk. Yes, ma'am. Sorry, ma'am. So we have a wonderful speaker to talk on management of osteopenia and osteoporosis.
There have been
Professor
4 talks,
Dr.
Madhvita. This is the 4th talk.
Yes, ma'am. Yes, ma'am. I thought 333. I was like thinking. So we have Dr. Sudha Sharma, ma'am, who is a former professor of OG at Jammu and Kashmir. And ma'am is also the president-elect of IMS. And she's also the managing committee member of PCO Society of India and honorary professor in IMA and the vice president of IMS. Over to you, ma'am.
Thank you. Thank you, Dr. Madhulika. And thank you, ICOG, for this invitation.
तो पहले मेरी ज्वेलरी संभालना बेटा उसको बुला रहा है.
Is this full screen?
Yes, ma'am. Yes, ma'am.
So I think we all are, after, listening to such good talks on osteoporosis and sarcopenia, I need not tell that why we are worried about our bone health in midlife, because there is a decrease in bone mass and new bone formation is outspaced by bone loss, and result is osteopenia and osteoporosis. So this is basically net decrease of bone per unit volume. It is underdiagnosed, undertreated osteoporosis in spite of the fact prevention and treatment options are available. And why we are so much worried about it? Because it has serious consequences. And look at this, the global distribution of fractures in 2050, Asia is going to have more than 51% risk of having fractures. So how do we approach to prevention of bone health? Lifestyle factors are responsible for nearly 10 to 50% bone mass and structure. And with every 10% increase in bone mass, there'll be a fracture risk reduction by as much as 50%. So nutrition and bone health would form the first, preventive therapy. Optimization of maternal nutrition and intrauterine growth is the first line of preventive strategy. So a well-balanced diet, calcium with vitamin D, has a crucial role along with other nutrients. So we all know what are the recommended calcium allowances: milligram per day during pregnancy 1200, post-menopause 1300 milligram. So calcium and vitamin D exert a synergistic effect with anti-resorptive agents on bone and in terms of fracture prevention. So only calcium and vitamin D, if taken, would have, a lot of effect on bone health. The preferred calcium, we all know, is the natural. Try to have as much as possible from natural source. Then if you are giving, extra calcium, 500 milligram, one time would provide the maximum bioavailability. Citrate salt is more kidney friendly, but elemental calcium is only 21%. And elemental calcium is 40% with carbonate. There are some concerns regarding calcium and, the heart problems, but the consensus is that calcium and vitamin D supplementation for women at all stages of life, initial evaluation and intermittent monitoring for cardiovascular and renal risk factors should be done once you are giving calcium. So the effect of calcium and vitamin D has been seen in a study with 36 months follow-up. Look at the fracture risk reduction on hip and non-vertebral fractures. Now, in the non-pharmacological treatment for osteopenia and osteoporosis, we should be consuming a nutritious food which should be rich in calcium. We all know the products which are rich in calcium, vitamin D, magnesium, potassium, vitamin K, green leafy vegetables and soyas, fruits, because vegetables and sufficient exposure to sunlight is beneficial for maintaining good bone health. Number 2 would be exercise and bone health. All types of physical activity can contribute to bone health, but we need to keep one thing in mind, that the effect of physical activity on bone will persist as long as you are doing the activity. So we have now weight bearing and high impact exercises. They should be done by those who do not have low bone mass, like, hiking, jogging, running, jumping. Then we have weight bearing and low impact exercises. The best ones, walking, treadmill or outside. Resistance training, weight or strength training exercises, wherein you move your body against, the gravity. Non-impact exercises, which help to improve balance, posture, and increase muscle strength. Then non-weight bearing and non-impact, they do not build the bone, but yes, they can be a part of exercise program. So these are the exercises which are important for us to have to maintain a good bone health. The weight bearing, the aerobic, the resistance training, and the balance training exercises. Now, we all know what are the fall preventive measures, but we always forget to take them. Stay physically active, try balance and strength training exercises. Your home should be fall proof. Get enough sleep, avoid or limit alcohol, stand up slowly in this age group. Use an assistive device if you need help. Then keep your hands free, use a shoulder bag, hands free to hold on to railings, choose the right footwear, and always tell your doctor if you have fallen since your last checkup, because sometimes there are silent fractures, even if you did not feel pain when you fell. Then there are other aspects of bone healthy lifestyle. Smoking. Smokers, they lose bone more rapidly, and in them fractures heal slowly. Alcohol. Moderate intake has no negative effect. 3 or more drinks, they are detrimental because of the degenerative metabolic effects, and they may inhibit calcium absorption. We should know what are the medication which we are taking or the patient is taking. Then always maintain a healthy body weight and avoid the uses of sodium and caffeine that also enhance bone health. Now, in the management plans, we have to evaluate the high risk category, exclude the secondary causes, universal counsel about lifestyle measures in all, and select appropriate treatment when needed. So when is the time when you have to treat them? If she has only osteopenia with no risk factors, then only instill lifestyle measures. But if she has osteopenia and clinical risk factors, apply FREX score and accordingly treat. So these are the osteoporosis medication. In pharmacology, we have anti-resorptive agents, we have anabolic agents, and we have other ones. In anti-resorptive, we have bisphosphonates still form the first line of drug, then HRT, Rankel, ligand inhibitor, that is denosumab, and SERMs. In anabolic, we have teriparatide, abaloparatide, and romosumab. So bisphosphonates, they still form the first line drug because they reduce both vertebral and non-vertebral fracture risk. Risk reduction is usually seen within the first 6 to 12 months. And the best part is the increase in BMD that occurs with prolonged use of bisphosphonate is maintained for 2 to 3 years, even after cessation, unlike with HRT. That's why we give drug holiday in bisphosphonates. So these are the 3 bisphosphonates which we use very common: alendronate, risdronate, zoledronate, and that is the percentage of risk reduction on spine and non-spine. And zoledronic acid has the maximum one. These are the preventive dosages. Why we are giving parenteral? Because this is preferred when the compliance with oral therapy is limited by esophageal irritation and there is poor absorption. HRT should not be used as a first-line treatment. Though An ultra-dose, low dose transdermal estradiol has been approved for the prevention of osteoporosis by US FDA. But this is the white paper on menopausal hormonal therapy, which was released in the month of October 2024 by International Menopause Society. It says that for prevention of osteoporosis, the women who seek MHT for menopausal symptoms in their late 40s or early 50s will have the additional benefit of reduced risk fractures and having good bone mass. But the treatment of established osteoporosis, estrogen should not be the first line approach because we have more potent agents available with us. Raloxifene, it preserves BMD over spine and hip. Fracture prevention is only at spine. Symptomatic women are not the candidates because it increases, vasomotor symptom. So the asymptomatic women without severe osteoporosis, 10 or more years post-menopausal are the best ones. Calcitonin, can increase bone mass. It has no effect on non-vertebral fractures, would have some, analgesic property also, but has been withdrawn because of risk of developing cancers. Parathyroid hormone, women at high risk of fractures, including those who have, T-score worse, less than -3, women with previous vertebral fracture, or those who are intolerant or responsive to anti-resorptive therapies and glucocorticoid-induced osteoporosis, as well as male osteoporosis are the candidates. So superiority, it increases BMD, spine by 8.6%, femoral neck by 3.5%, and fracture risk reduction is very high. It has a positive effect on fracture healing, fracture repair, time is shortened, and improvement in callus bone formation and development. It reduces the time of immobilization and complications. But consensus about the dose and duration is safety beyond 2 years is not known. The current recommended dose is 20 micrograms daily subcutaneous. PTH, parathyroid followed by anti-resorptive therapy, will produce better long-term protection against fractures. So teriparatide appears to retain its anabolic effect in postmenopausal women with osteoporosis who were previously treated with long-term bisphosphonates. Strontium ranelate used to have a dual action mode of action and good, fracture risk reduction, but again has been withdrawn because of various reasons. Denosumab is a bone anti-resorptive drug. FDA approved indications are osteoporosis in postmenopausal women at high risk of fractures, in men with high risk of fracture, and corticosteroid-induced osteoporosis. Now, safety, various trials have various trials have been done to see the safety, but now the clinical recommendations and the monitoring is all patients under denosumab therapy should take calcium and vitamin D to avoid hypocalcemia complications. So the monitoring of calcium, magnesium, and phosphorus in patients with CKD. Denosumab is currently contraindicated in hypocalcemia, pregnancy of course, and in those with history of hypersensitivity reactions. Now, duration of therapy, 60 milligrams subcutaneous once in 6 months. So it is very important to note that not even a single day of delay should be there because the BMD fall is very rapid if you miss it. Abaloparatide, another anabolic treatment option, it improves the bone formation and resorption, but I don't think it is available with us and we are not using it. Even romosozumab is for, promotes bone formation by inhibiting sclerostin, but again, not available. Isoflavone and osteoporosis, a lot of conflicting reports are there, but data is less. So if you are otherwise giving it, some preventive effect would be there on the bone, but not for the treatment of osteoporosis. So these are the list of neuropromising, agents. We have, ODAN, fracture reduction trials are awaited for this. This is the key enzyme which is involved in the degradation of organic bone matrix by osteoclasts. So huge list of neuropromising agents. Why we have a list of neuropromising agents because bisphosphonates are contraindicated in CRF. HRT is not the first line. Strontium has been withdrawn. Calcitonin is the poor choice and has been withdrawn. SERMs are not useful in early menopause, and denosumab and teriparatide, they have, the cost is still the issue. So if you see the comparative efficacy, I just want to highlight here that see only calcium and vitamin D has a good fracture reduction rate when we compared it with HRT. Then zoledronic acid has the maximum and also the denosumab. So friends, this is one of the best slide. I always speak in my, presentations that two of my loved ones, they suffered from osteoporotic hip fractures. So in the process, I learned few things that I am the daughter of an osteoporotic mother. Hence, I am at high risk of having osteoporosis. So I better take care of myself. And also I learned that what is minimal trauma fracture. When you fall from a standing height, standing, if I am 5'2", if I fall from 5'2" and break my bones, that is minimal trauma fracture. What are the commonest sites of fracture? Because they have trabecular bone. And this one, men have more BMD than women at any stage of life because they have, higher BMD initially when the BMD is being gained. Though, so their skull may be hard, but how about gray matter? I think we all have to think about it. So again, if you want to celebrate any event, don't go beyond 2 drinks because then it would be detrimental. And this one is, I will never forget that I should have given some pharmacotherapy to my mother after first fracture. As at that point of time, I did not know it because then she suffered another fracture. So once the fracture has occurred, one should give, the pharmacotherapy. And I learned in the process that what it means, socio-economic burden and personal sufferings. So healthy bones are important for a healthy body. Don't forget what you do to your bones today, or your bones will do to you later in life. So make a commitment to last a lifetime. Thank you. Thank you so much.
Thank you, Dr. Sudha. As usual, it was amazing. And when we talk about bone health, I think we talk from bottom of our heart. Sarcopenia, Dr. Swarna. So I think all of us are kind of, when we talk from bottom of our heart. So without any delay, Madhumita, can we go to session 2, please?
Yes, ma'am. Thank you for the wonderful talk, ma'am. Now moving on to the session 2, I would like to introduce our chairpersons. Dr. Yeah, can I have slides, please? Dr. Neelam Agarwal. Dr. Neelam Agarwal, she is professor at PGA Chandigarh and also the founder president of Stillbirth Society of India and the past president of Indian Menopause Society. For the next chairperson, we have Dr. Revati Janagiram ma'am, who is who's the past vice president of Foxy and also ma'am is now the and past president of Madurai OG Society and the president of Indian Menopause Society in Madurai chapter. Welcome, ma'am. Next, we have Dr. Rajendra Singh Nagarkatti, sir, who's a past Vice President of Foxy and also the past Chairperson of Food and Drugs Committee of Foxy. Welcome, sir.
And he is also passionate about his, his knowledge. He is very knowledgeable about menopause. So that is the reason of, calling him because he's really passionate about menopause.
Yes. And we have a very interesting talk by Dr. Ratnabali Chakrabarti ma'am on shifting risk of cardiovascular health landscape in post-menopause. Ma'am was the past president of Indian Menopause Society and also vice chairperson of All India Women's Cell of IMA and state coordinator of Mission Pink Health Project IMA. Over to you, ma'am.
Before when the Dr. Ratnabali is sharing, there was some emergency with Dr. Ambuja. She has not been able to take the lecture, but I would request Dr. Ratnabali to share her knowledge because she has tons of knowledge on cardiac health, and that's one of the passionate, subjects which she talks about. So let's hear insights from Dr. Ratnabali.
Good evening, everybody. Can I share my slides now?
Sure, ma'am. Yes, ma'am.
Yeah. So, share. Is it okay?
We're not
Hello?
we're not
Can
yet
you
able to see it.
Fine. Take 1 minute. Did you share it in the program? Share today, today, coffee choosing. Share to collaborate. Did you share the link? And these are the slides. Yeah. Screenshot করেছেন ভাবে? No. স্ক্রিন শেয়ার করতে হবে তো এখানে এটা ছোট করে মিনিমাইজ করে দিই স্ক্রিনটা দেখতে পাচ্ছি নিরাশ করে স্ক্রিন
There will be a green share button right at the bottom of your screen. Right at the bottom. And if you're in full screen mode, you see it. If you're in half screen mode, then you don't see that button.
ফুল স্ক্রিন করতে হবে এটাকে ফুল
Full
স্ক্রিন
screen
করে
mode.
And ma'am, first open your PPT and then share. It will appear on the share screen tab.
আবার ছোট হয়ে গেছে এই তো share has been done so
Then you select, it'll show your desktop. So your presentation should be on the desktop. So this will show your desktop. And from the desktop, you select.
It's on the desktop and I've shared.
But we can't see your screen, Dr. Attabali. Can you mail me your PPT? I can share from your side. Meanwhile, Dr. Pushpan can give her talk.
No, but I have to do it now, not today, not tomorrow.
Ma'am, first open your PPT.
Just open it on your desktop.
And now
PPT
you
is
can
open.
share.
Now open
PPT.
Zoom.
Now open Zoom, then a green share button. And yeah, it's
yes,
coming.
Yes, we have seen it.
Yeah.
Yes, ma'am.
Now I have to see
Now,
Good.
Yeah. Is it
Yeah.
okay?
Yes.
Yeah, it's done, ma'am.
Okay.
Make it your full screen, ma'am.
Go to your first slide.
Yeah.
You can
Is
make
it
it full
okay?
screen. Just go on to slideshow, ma'am.
Slideshow.
Full screen.
Yeah.
Okay.
Yes, ma'am. Yes, ma'am. Perfect. Yes, ma'am.
Okay. Thank you very much. It's always a problem with me. Anyway, so we Indians are very happy today, and I am happy to see everybody here, Nirja, Aruna, Anju Soni, everybody. Now, the point is, we Indians are happy now because we have become the fourth largest economy. And if you consider 2 decades back, we were the 13th. So from 13th position, we have come to 4th, and we have to pay something for it. And what did we pay? Our coronary artery disease chances were 45% 22 decades back, and now it has increased in postmenopausal women up to 300%. So just any problem, Anju?
No, sorry, ma'am.
Oh, so in order to increase our, the social condition, the economic condition, we have given our health to it. And therefore, these postmenopausal women who are now having almost in an epidemic form, the cardiovascular health problems should be dealt with. One problem that I can see that we have not prevented the disease. What we did throughout our tenure was treat the disease. There are a lot of doctors who are doing, medical treatment for the cardiovascular problem, the intervention, the surgeries, but it's easy to prevent, which we can do as the caretaker of the 40 plus women's health, that we can do. And we always think that cardiovascular disease means coronary heart disease. But apart from that, there are a lot of others coronary artery disease, the strokes, the spontaneous coronary artery dissection has become very important nowadays. There are heart failures without the reduced ejection fraction and many much so, which all can be prevented if we prevent all the metabolic problems much earlier. So if you look at this, that coronary artery disease increased by 300% over the past 2 decades in the 40 plus Indian women. The mean age of heart attack has decreased. It has become 59 years. The mortality rate increased from 25% of all deaths after the age of 40. The hypertension has become 30.5% and diabetes has become 12%. So with all this burden, and many of these can be prevented by us, we just have to change our mindset. The mindset was earlier like this, that a heart attack can happen to a person, a male, an obese, aged more than 65 years, having hypertension, having diabetes, and with a heart attack lying in on bed. But nowadays we find it's not so. Even a 40 years old woman are having the heart problems, which can be prevented. And therefore, today, whatever I will be telling is almost preventive. And if we pay attention, you will find that we are not talking much about treatment. We are talking about prevention. So this sex and gender difference, which was found earlier, that is 30% of the men are having at the age of 40 years, heart attacks and strokes. Women are not much behind. It is 50% of them are getting the problem. Similar deaths, if you look at the deaths caused by coronary heart disease, other cardiovascular disease, the congenital heart disease, all are almost same. We are lagging behind a bit. If you look at the remaining lifetime risk at the age of 40 years, even there, in the woman, it is 50%, in men, it is 33%. Of the heart failures, of strokes, the similar percentage is being shown everywhere. So let's see the prevalence of cardiovascular risk, which we can prevent and we are dealing with, is almost 2030, 5 years we are waiting for to reach 2030. Almost 24 million people will die of cardiovascular disease. So how many of them are going to be having involved in the disease? That is
Dr. Ratnabali, you can, I think you have your bandwidth.
Hello. Yeah. Hello.
You can switch off
Yeah,
your video.
Yeah. Can you see now?
Yeah, we can see. You can switch off your video. Maybe that may be helpful.
So, prevalence rates among the women will keep pace with those of men across all ages. Now you can see over here, if we take 40 years, why we have taken 40 years? Because between 40 to 60, the average percentage of cardiovascular disease is almost 40%. So a lot many can be, prevented from having it if we take care. So in Indian scenario, which is a growing country and is becoming a world leader, going to be a world leader right now. So more than 9 million deaths due to coronary artery disease, which has happened in 1990, almost 300% of that has increased now. So you have to keep in mind the statistics. As we were earlier talking about osteopenia, fracture, death due to it, now sarcopenia. Similar, we also have problem with the cardiovascular problems. So why is it true that after menopause cardiovascular diseases increases? There is an obvious relationship. This came up in 2022, and this was done by the American Heart Association regarding the menopause transition and cardiovascular disease risk. Implications of timing of early prevention. This is what I would like to stress upon. Timing for early prevention, a scientific statement from the American Heart Association. We are not looking into it, not paying attention, but just look into it, what menopause is actually doing to us, that it is causing increased chances of type 2 diabetes, obesity, and lipid disorders, hypertension, smoking, and sedentary lifestyle all are present in the Indian woman. Because we are now have a good amount of money, we are sitting in front of TV and spending time. These, along with internally, we are having activity of the sympathetic nervous system, which increases, giving rise to our hot flashes and others. And yes. Then oxidative stress increases at this age. The plasma renin activity increases, the endothelin concentration increases, and this gives rise to the changes in the blood vessels, increasing the vascular tension. There are inflammatory markers that increase, so inflammation of the blood vessels and reconstruction of the arteries at this age, giving rise to, okay, some protection to the vessels which are becoming thinner and occluded. But however, these are also causing problem. Estradiol definitely had protective role. So when we are not menopausal, they were having, we knew from our student days on the blood vessels, there are immense effect of the estrogen. And nowadays we know that estrogen increases angiogenesis, it increases vasodilatation. So both of them have got a protective role. Estrogen also decreases the oxidative stress and antioxidant properties. Estrogen have got an immense amount, which we do not highlight. It also increases the cell survival. The estradiol has got effect on the fibrosis. How? It decreases fibrosis migration. So in the blood vessels, due to fibrous tissue, when there is deposition of the lipids causing atherosclerosis, that can be prevented. It decreases collagen. It deposits MMM and angiotensin 2. Mitochondria at the level, pro-survival and anti-apoptotic, which we all of us know very well. And they also decrease the ROS production. So it has got action in the multi-level. So when after menopause, the estrogen cardioprotective effect of estrogen is decreased, we know that the HTLC level, which was maintained high by estrogen, decreases and LDL level increases, maybe triacylglycerol level also. Apart from that, estrogen also causes the hepatic expression of the apoprotein gene. Consequently, it affects the lipid and lipoprotein metabolism. What happens is, estrogen, all of us know, has got effect on the bile acids in the liver, and they accelerate the conversion of hepatic cholesterol to bile acids, and this increases the expression of the LDL receptors on the cell surface. So mass clearance of the LDL, though LDL level increases in our blood, there is mass clearance of LDL from the plasma. So if a menopausal woman who has got less estrogen of the body takes estrogen, in her case, LDL level will gradually decrease. It increases the production of the apolipoprotein A, and these cardiodefensive effect, which is lost after menopause, if we give at the proper time, along with the other holistic approaches, it protects the heart. Now, estrogen hormone regulates even at the cellular level directly by the mRNA production for specific proteins. 17-beta estradiol specifically, not others, regulates the rate of synthesis of the structural apolipoproteins for VLDL and HDL in the liver. Conversely, it enhances the rate of apolipoprotein A and 1 and 2 synthesis, thereby increasing the HDL concentration, which is atheroprotective. So ultimately, we have to assess who is at a higher risk of cardiovascular problem or not. So we would look at the blood pressure, if there is increased blood pressure, and also at the subclinical vascular disease. So a lot of women nowadays have the problems of SLE. They have got problems with rheumatoid arthritis. So we have to look specifically into those women. And this is because the increased carotid and femoral artery intima media thickness, which can be measured very easily by ultrasonography we are doing at our clinic. And in the coronary artery calcium score, that is also easy to measure, and the arterial stiffness and flow mediated dilation. Diabetes, all of us know, is in almost an epidemic in our country, and therefore from the age of 40 we have to find out the high risk of developing diabetes by looking at their family history, her obesity, her other features, and therefore we can prevent diabetes related cardiac problems. Menopause before the age of 40 increases the risk, therefore should not remove the ovaries unnecessarily while doing an hysterectomy. Obesity, we must be going on talking about obesity to each and every patient. And all of you know that nowadays in our clinic, from the 12 years of age, a girl coming with the age of 86 kgs. And these are those where we can prevent a cardiovascular accident later in life. Lack of exercise is now predominant in our society. We have to put them very regularly on exercise. And from Menopause Society, we are taking care of the yoga. But apart from yoga, the cardiovascular exercises has also to be done. So this is very known to all of us. What are the high risk? If a woman with surgical menopause less than 40 years, the hypertension chance very much increases, coronary heart disease increases, obesity increases, diabetes increases just after removing the ovary, which many of us will do unnecessarily. If the menopause is natural before the age of 40, all these chances are much less. And if the menopause is after the age of 40, these are, at a very balanced situation. If we give menopausal hormone therapy at the right time, you can see all the arrows are looking down. So chances of cardiovascular disease much, much less in those women. Now coming to the last part, that is how should we now identify those women? And all of us know about metabolic syndrome, which will be also discussed. And if we know what is metabolic syndrome and we can identify, we can easily prevent this. Any three of these five markers you can identify as a metabolic syndrome: central obesity, blood pressure high, triglyceride high, low HDL, and insulin resistance. And there is a flow chart. I'm not going into detail, but all of you know that metabolic syndrome is a feature of one of the features is insulin resistance. You know how to say it by acanthosis nigricans and other features. Abdominal obesity from the upper part, that is the waist circumference, then measuring the lipids in blood, dyslipidemia, so on and so forth. And if we can identify, there is a very good trial report with almost 1,000 women over 9 years, where it is shown that after menopause, as the amount of estrogen decreases, though testosterone does not increase, but there is ratio-wise progressively dominates and therefore gives rise to the changes in the lipid profile and increased chances of the cardiovascular disease because its effect directly on the vascular walls as well. There is another trial report where almost 33,315 women, 107 trials were taken together, where MHT is given in the different forms. And the result was HRT, when given at proper time, reduces abdominal obesity. Just opposite, people think if we give hormones, we'll gain weight, we'll have abdominal obesity, just reverse of it. The chances of insulin resistance, new onset diabetes, the lipids, blood pressure, adhesion molecules, and procoagulant factors, all of them decrease when the woman is put on HRT at a proper time. And these are the women who do not have the diabetes or reduced insulin tolerance, but those who have their fasting glucose, their insulin tolerance, or improve after giving HRT. And how to identify, because we are getting girls and women in the form of PCOS at very early in their age or in their reproductive phase. And we know that metabolic S syndrome and its components are common with PCOS. If we identify PCOS, if we prevent metabolic syndrome, we can prevent the chances of cardiovascular disease. And metabolic syndrome is a twofold increase in the chance of cardiovascular disease, fivefold increased chance of diabetes, And lipid profile, we have done personally in our trials in our clinic also. 70% of the PCOS girls and women has got the deranged lipid profile. So how to know about this in a postmenopausal woman? Because she is not going to have any follicle in the ovary. If you do a sonography, you cannot diagnose PCOS. So ask her about the history of irregular mens. Look at the Hirsutism or other current biochemical evidence of hyperandrogenism. You can also measure the SHBG, not usually done. Third, a personal history of infertility or repeated abortions. You measure the central obesity and the waist circumference more than 88 centimeter, and insulin resistance are defined either as HOMA value. We do not do this, but fasting plasma glucose level, or you can measure very easily. And you will find we are doing this in our clinic also, that PCOS girls and women are having increased levels of LDL continuously from their childhood days. In us, in others, not us, but others who do not have PCOS or metabolic syndrome, in them after the age of 45, gradually the LDL increases and chances of atherosclerosis happens. But in PCOS, they are depositing LDL continuously from their childhood as soon as they start, consuming any sort of the carbohydrate food. We have done these trials in our clinic, and we have found that coronary artery heart disease risk and lipid profile in PCO. I'm not going into details. We have measured the D3 level and insulin resistance, that also correlated. We have done the molecular biomarker in a genetic polymorphism in vitamin D receptor gene, that also correlated. And therefore, we can say very well, now we are doing this, measuring carotid intima thickness in PCOS woman after 4th decade, and that is also correlating. We are now measuring the, very easily what you can do is measuring the waist circumference, taking weight and height, the BMI, the blood pressure, one sugar level. That is enough to diagnose that this is a woman who can have Metis syndrome. Then you can go on measuring, lipid profile, the hemoglobin A1C, TSH, so on and so forth. So this is a Cochrane collaboration trial report in 41,000 women. And the author's conclusion was HT is not indicated in the routine management of any chronic disease. However, if it is given for a short time in an early age of a healthy young woman within 10 years of menopause or before 60 years, definitely they will protect against the coronary heart disease, reduce the new onset diabetes mellitus. These two are an epidemic in our country. And from International Menopause Society on the cardiovascular disease, this dictum has the recommendation has come, that is the cardiovascular disease is the principal cause of morbidity and mortality in postmenopausal women. We think about breast cancer, we think about uterine cancer, but cardiovascular disease is an epidemic. There is evidence that estrogen therapy may be cardioprotective if given at a proper time, and initiation of HRT in elderly women or those who are more than 10 years should not be given. That increases the risk of coronary event. So thank you very much for your patient hearing, but this is not only listening. We should think about it. We should act accordingly. And we are coming up next what to do about it in our next meeting. Thank you very much.
For information. Yes. Thank you so much.
Dr. Revati.
Yeah. Good evening, all. Thank you, Dr. Ratnapalli. Really a wonderful talk. And you clearly mentioned the risk factors for cardiovascular disease around menopause. And we gynecologists, being the first point of contact, we should have a clear idea about the risk factors, especially the modifiable risk factors, so that we can institute timely interventions to avoid severe risk in future. Threatening sequelae can be definitely avoided. And really, you have mentioned nicely how estrogen protects the cardiovascular system before menopause and after menopause, how we have to take care of it by our theme of this year, lifestyle modification. So lifestyle medicine is very, very important. Thank you very much.
Thank you so much, ma'am.
Somebody has asked when to offer carotid artery intima thickness and all those things.
Rajendra Katkati, sir. Dr. Ambuja is not there. Can
Yes,
we
ma'am, it's gone for an emergency.
Can we invite Dr. Pushpa Siti, please?
Yeah.
Yes.
Yeah.
Rajendra Singh, sir. Yes. ma'am. So you're muted, sir.
I think she's there.
Rajendra Singh, sir, is muted.
There only.
But Desi sir, you're muted.
Yeah.
Yes,
Yes. Hello. The host was not allowing me to unmute. That is the problem. Thank you, Dr. Ratnaboli. She has really narrated in lucid language. At postmenopausal women, they have an increased risk of cardiovascularity due to not only estrogen, but increased LDL, lowered SDL, increased blood pressure, and increased risk in early or surgical menopause and excessive weight gain. These all plays major role. She had explained very nicely. Thank you, Dr. Ratnaboli.
Thank you very much.
Thank you so much, sir, for your comments. Now, moving on to the next talk, I'm happy to introduce Dr. Pushpa Shetty, who's the past president of Indian Menopause
I think
Society.
we can go on. I'm just past president Indian Menopause Society. Let's go on after that. Shall I share the screen?
Yes, ma'am. Sure, ma'am.
Meditation is her favorite topic.
Yes, ma'am.
Yeah. So, a very good evening to all of you, and thank you so much, Anju, for having me here. And once again, amidst my most favorite people of the Indian Menopause Society and Foxy, and being with them after quite some gap. And thank you for letting me talk on my very, very favorite topic, and that was metabolic syndrome, which I used to love talking to in my presidential year. So when we talk of metabolic syndrome, a lot of it has been, it is something very common to what Dr. Ratnabali has said, because very many factors are common between cardiovascular disease and when we talk of metabolic syndrome. So metabolic syndrome per se is not a disease. It is basically a combination of interconnected physiological, biochemical, clinical, and metabolic factors that directly increase the risk of CVD and type 2 diabetes mellitus. And all of these in the end lead to increase in morbidity and mortality. It comprises abdominal obesity, insulin resistance, hypertension, dyslipidemia, and hyperglycemia. So what is the incidence? There has been a dramatic increase in the incidence of metabolic syndrome in our country as well as in other South Asian countries. Maybe it is because of the sedentary lifestyle, wrong eating habits, socioeconomic transitions, a lot of availability of all sorts of food and, financial betterment of people, and food is readily available. Rural to urban migration, and our ethnicity. Ethnicity has to be remembered because of our ethnicity, WHO has now, they've revised the BMI parameters for the Asian women. So what is the prevalence? In India, prevalence is in the perimenopausal women, it is 22.2%, rising to 32.2 to 48% at postmenopause. So this goes to prove that menopause has a role in the incidence of metabolic syndrome in women. It is 1.5 to 2 times more common in women than in men, and an average of 40% of Indian women are affected. Now, what is the criteria of diagnosing metabolic syndrome? There are very many criteria given by the different organizations, but the two that we follow are from the IDF, that is the International Diabetic Federation, and the National Cholesterol Education Project, Adult Treatment Panel 3, that is NCEP ATP 3. So these two we are going to talk about. Diagnosing according to the IDF. Now, in IDF, prevalence of central obesity, that is the waist circumference being 80 centimeters or more, and 2 or more of the following parameters, of the following 4 parameters, is taken as diagnosis of metabolic syndrome. So prevalence of central obesity, waist circumference more than 80 centimeters, and blood pressure 130/80 or more, fasting blood sugar 100 milligram or more, serum triglycerides 150 milligram or more, serum HDL less than 50 milligram or more. So out of these 4 parameters, 2 have to be present, and 1, that is the waist circumference, is taken as a permanent parameter. Now, when we talk of diagnosing according to the ATP 3 criteria, the 3 or more of the following 5 factors are taken as diagnosis of metabolic syndrome. Here, there is no permanent one, parameter like we took in the ITF. So abdominal obesity, that is waist circumference more than or equivalent to 80 centimeters for the Asian women, triglycerides more than or equivalent to 150 milligram, HDL cholesterol 50 milligram or less, systolic and diastolic blood pressure equivalent to or more than 130 by 85 milligram mercury, or patient receiving drugs. Even if the blood pressure is normal, if the patient is on drugs, it is taken as a parameter to be counted in the diagnosis of metabolic syndrome. Fasting plasma glucose level more than or equivalent to 100 milligram. So here are 5 parameters, and out of these, any 3 have to be present to diagnose metabolic syndrome. So the difference between the two, the IDF and here, it is that for the NCEP criteria, abdominal obesity is a component of the syndrome, but not a prerequisite for diagnosis. Whereas in the IDF criteria, they use the central obesity as a mandatory criteria for diagnosing metabolic syndrome. Now, what are the risk factors? Risk factors are very many: age, female sex, ethnicity, central obesity, insulin resistance, fiber intake, genetics, patients with PCO, menopausal patients, patients on HRT, birth weight, chronic inflammation, smoking, excessive intake of alcohol, and lack of physical activity. These are the very, very many criteria that you have as risk factors for menopausal syndrome. Now, what leads to the metabolic syndrome? What leads to metabolic syndrome? What is, in broad sense, pathophysiology? Counting from the top, genetic factors. Now, genetic factors we do not have a control upon. Number 2 is fetal programming. The fetal programming is a very, very important part here, because the environment the fetus gets inside utero is at times responsible for the baby to become a metabolic syndrome patient when it grows up. When the environment is hostile, like mother having malnutrition diet, or mother having a lot of stress during pregnancy, or physical inactivity, or maternal smoking, which is a very, very common occurrence these days amongst the youngsters, genetic and sex-specific effects. So all these lead to a different, a very hostile environment. And these babies, when they grow up, they are prone to becoming developing type 1 diabetes and ultimately landing up into metabolic syndrome. And this is called fetal programming. Then excessive dietary intake or lack of exercise. Of course, these 2 things are, we talk about very often when we are in the menopausal medicine. So all these factors put together lead to insulin resistance. Insulin resistance in turn leads to high insulin levels, high IGF-1 levels, leading to metabolic syndrome. There is visceral obesity leading to chronic inflammatory cytokines release and the depression of the protective cytokine, that is adiponectin. So when the alteration happens, this leads to metabolic syndrome. Then there is HPA dysregulation. HPA dysregulation leads to increased levels of cortisol, low growth hormone secretion, hypogonadism, renin-angiotensin system dysregulation, leading to metabolic syndrome. Then atherogenic dyslipidemia. Atherogenic dyslipidemia leading to low HDL, high LDL, and high triglycerides, leading to metabolic syndrome. So this is in broad the causative factors and the pathophysiology, how the metabolic syndrome comes around. Now, one of the basic parameters of metabolic syndrome is insulin resistance. Insulin resistance normally we think will lead to type 2 diabetes, which is one of the components of metabolic syndrome, but insulin resistance leads to so many other problems in the body, which we should enumerate. Type 2 diabetes, of course, hypertension, impaired glucose tolerance, central obesity, polycystic ovary disease, hyperuricemia, acanthosis nigricans, decreased fibrinolytic activity, dyslipidemia, atherosclerosis. So such a broad parameter, the spectrum you have, the effects where insulin resistance can affect. Now, central obesity is another one area which is taken as a very important parameter of metabolic syndrome. When there is central obesity, there is increased number of adipocytes around the visceral areas. There is increased visceral fat. When there is increased visceral fat, what happens? The adiponectin, or the protective cytokine, the secretion decreases. When the secretion of adiponectin decreases, it leads to insulin resistance. There is increase in the secretion of inflammatory cytokines, which are TNF alpha, IL-6, and this leads to increased inflammation in the body. The increased adipocytes leads to increase in the free fatty acid circulation in the free fatty acids in the circulation, and this leads to decreased degradation of apolipoprotein B by the liver, leading to increased triglycerides. The increased free fatty acids lead to increased hepatic lipase activity, which leads to increased LDL and decreased HDL particles. So insulin resistance and central obesity, this is the role that they play in the formation of metabolic syndrome. Now, why is the fat distribution important? When we talk of fat, is it obesity only or is it central obesity? It is basically, we have to recognize that only obesity does not per se have a role in metabolic syndrome, but it is central obesity. And how does the menopause play a role? You know, when this is the gynecoid type of fat distribution. And when there is gynecoid type of fat distribution, this type of fat accumulates around the hips, thighs, and buttocks. And this does not play a role to increase the risk of CHD or metabolic syndrome. But when the fat is distributed around the waist, which is the male type of fat distribution, this type of fat distribution is associated with an adverse lipid profile, particularly increased triglycerides, low levels of HDL, insulin resistance, and increased risk of cardiovascular disease. So why do we talk of central obesity and gynecoid obesity? What role does menopause play in this? Now, obesity is an independent predictor of CHD and diabetes. Now, what is happening during menopausal transition? During menopausal transition, there is a redistribution of body fat that is happening, and the fat around the hips and the thighs is going and getting deposited around the waist. So there's a redistribution because of the falling estrogen. The comparative increase in androgens leads to a male type of distribution of body fat. The women always talk that their waistline has increased, though their weight will be the same, but the waistline has increased, and they always feel we have put on weight. So, and when the waistline increases, when there is redistribution of body fat, it predisposes them to metabolic syndrome because of the role the adipocytes, increased number of adipocytes play in formation of the metabolic syndrome. So this is the famous pear-shaped and apple-shaped obesity. So the pear-shaped obesity is getting changed to apple-shaped obesity in menopause, and the woman really doesn't know what's happening and how she is being, she's getting predisposed. The central obesity will lead to high blood pressure, high triglycerides, low HDL, insulin resistance, and coupled with the bad lifestyle will lead to formation of metabolic syndrome. So is menopause a risk factor? Yes, menopause is a risk factor. Why? Because there is estrogen withdrawal, there is comparative androgen excess. And what does this lead to? This leads to increased total fat mass, increased visceral abdominal fat, increased subcutaneous abdominal fat, increased ectopic fat storage. There's ectopic fat storage, especially around the skeletal muscles and liver, and decreased peripheral, or that is gluteofemoral fat, reduced total and peripheral lean body mass. So when there is ectopic storage of fat around the liver, you have that non-alcoholic liver, fatty liver. When it is around the skeletal muscles, you have obesity, the skeletal muscle obesity, which is common post-menopause when the muscle mass is decreasing and the fat storage around the muscles is increasing. Now, another very important factor here is the waist-hip ratio. So what is happening to the waist-hip ratio? We said that the waist measurements are taken as a parameter in the metabolic syndrome. And for the Asian women, it is taken as more than 80 centimeters. So more than 80 centimeters, a risk factor for metabolic syndrome. In men, it is more than 94 centimeters. So the desired ratio between the waist and the hips, and where will you measure the waist and the hips? This is at the fullest point and the narrowest point. So when you measure this and the ratio between them, it is taken as 0.8 or less in women, and in men it is 1 or less. So when this ratio increases in men and women, this is a parameter taken as a marker for metabolic syndrome. Now, coming to sarcopenic obesity, and this is what I was talking about, the sarcopenic obesity and menopausal syndrome. Skeletal muscle is relevant to major organs involved in insulin-induced glucose metabolism, and loss of muscle mass, which happens during menopause, leads to insulin resistance and metabolic syndrome. Skeletal muscle loss and intramuscular fat accumulation around the muscle causes metabolic abnormalities leading to oxidative stress, inflammatory cytokines, mitochondrial dysfunction, and insulin resistance. The synergistic effect of fat tissue and muscle led to the concept called sarcopenic obesity, and this is defined as a combination of high body fat and low muscle mass. And we all know that post-menopause, the muscle mass decreases. That is why we always advise our patients to do strength training, which maintains your muscle mass. Now, oophorectomy or premature menopause, what effect it has on the metabolic syndrome? A meta-analysis showed that women having surgical menopause at a younger age suffered a 1.5-fold higher risk of metabolic syndrome in comparison to women with a natural menopause. So it goes to show the role estrogen plays in the metabolic syndrome. I mean, how women are protected and how post-menopause, this incidence increases. Now, coming to oxidative stress and the telomere shortening, we all know that long telomeres, healthy life. Shortening telomeres because of the various factors nowadays, pollution, oxidative stress, and so many other factors. Shortening of telomere will always give you unhealthy, an unhealthy body where diabetes, hypertension, heart disease, and all these parameters forming metabolic syndrome become very common. Metabolic syndrome is characterized by a series of different metabolic abnormalities associated with oxidative and decreased antioxidant protection mechanisms. This predisposes to telomere length shortening. Promoting healthy lifestyle with physical activity, the use of nutraceuticals and senolytics is very important for these patients, and this delays the telomere attrition and decreases the oxidative stress also. This helps in responding in time to control the metabolic syndrome and prevent the development of chronic degenerative diseases, which really decreases the quality of life of these patients. So if this is followed with proper, these nutraceuticals and proper lifestyle changes, you can always improve the quality of life of your patients. So longer telomeres, we all know, a healthier life, and shorter telomeres, unhealthy life. So what is the management strategy that we have to follow? So coming to management, identify the women at risk. Whenever you have a woman in your OPD and you see that she's postmenopausal, obese, depressed, and having hypertension, diabetes, and she don't know what's happening to her life, just mark her, just sort of counsel her, even if she's not come to you for that problem. So that is how you can always show her the way. So what should be your treatment goals? The treatment of risk factors should be the priority. Primary goal is to reduce the risk of CVD and to prevent type 2 diabetes mellitus from happening. Therapeutic lifestyle change, always a mainstay of any treatment that you would be giving. Physical activity and diet modifications are indicated for the long-term treatment of metabolic syndrome by reducing the body fat. First-line therapy directed towards major risk factors. Pharmacotherapy, if dyslipidemia is present and if it is indicated, should be instituted. And what are the NCEP3 guidelines? What they say about the clinical management of metabolic syndrome? They say manage the underlying cause first. Weight control helps in lowering LDL levels and reduces the other risk factors. So weight control is very, very important. Physical activity increases HDL, decreases VLDL and LDL. Medications, wherever required, aggressive dietary interventions, these are required according to the NCEP3 guidelines. Managing lipid and non-lipidic risk factors are very important. Treat hypertension with ACE inhibitors if it is a drug of choice. Beta blockers cause weight gain and thiazides alter insulin resistance. So see what is the drug of choice for your patient. Aspirin in high-risk patients, metformin or whatever medicine you want to institute for patients who are diabetic or have pre-diabetic. Now, according to the NCP3 guidelines, they say treat LDL cholesterol first. So what is the target area they specify and what is the goal? So they say if CHD and CHD risk is equivalent to 10-year risk equivalent of the CHD is more than 20%, then the goal of keeping LDL is less than 100 milligram per DL. But if there are multiple risk factors, more than 2 risk factors present, and the 10-year risk is less than 20%, then you have to keep LDL at less than 130 milligram. Institute weight control. Even at 10% weight from the baseline, if it is reduced, can show marvelous improvement in all the factors. Institute physical activity, at least 30 to 60 minutes, 5 to 7 times a week, or whatever the patient can take. Monitor treatment of hypertension. Try to keep the blood pressure less than 130 by 85. And These are the guidelines according to that you should manage LDL, and this will give her a better profile as far as managing her cardiovascular risk assessment is also there. So once the menopause takes place, even the resting metabolic rate decreases by 40 to 70 calories per day. So even if you're not doing anything, you are still, declining estrogen can decrease your resting metabolic rate. So that is why patients who are even exercising, they feel it does not show that much effect because your basal metabolic rate is basically gone down. So when you think of treatment, how should you plan? At the base of the pyramid should be your diet and physical activity, that is lifestyle changes. Then comes the pharmacotherapy, and at last is surgery. Now, what are the dietary interventions that we should take? Reduce the calories, reduce saturated and trans fats, reduce sodium, reduce simple sugars, increase whole grains, increase fruits and vegetables, eat fish 1 to 2 times per week if you do take fish, use mono unsaturated or polyunsaturated oils, reduce alcohol consumption, and stop smoking. Now, alcohol consumption, as of now, they say, social drinking is allowed. It's not supposed to be harmful. But smoking is absolutely no. But as of today, I've talked to so many cardiologists, and they say in the coming times, alcohol will be a no-no, just like smoking is a no-no as of today. Now, how should the nutrition be balanced? Carbohydrates should form 50 to 60% of the total calories, protein approximately 15%, total fat 25 to 35% of calories, where the saturated fat should be minimal, polyunsaturated up to 10%, monounsaturated up to 20%, and fiber 20 to 30 grams per day. Total calories taken, the decrease in total calories should be try to make it 500 to 1000 kilocalories per day, where you decrease the calories in food and sort of use the calories in your exercise. So that sum total should be at least 500 to 1000 calories per day, so that at least 1 to 1.5 kgs you reduce in a week. Carbohydrates should be derived always from, complex carbohydrates like whole grains, fruits, and vegetables. So a word about
I'm sorry to interrupt. You're beyond your time, ma'am.
Yeah, I'm just finishing. So
Yeah,
Mediterranean diet is very important. Mediterranean diet has a lot of, the protein comes from lean meat, eggs, the carbs come from complex carbohydrates like whole grains, and they have a lots of fruits and vegetables. So Mediterranean diet has been proved to be helpful in patients who are at risk of cardiovascular disease or diabetes. So here is the comparison between the Mediterranean and the Western diet. And Mediterranean diet is actually taken as a, it is basically as good as a medicine. So the people in the Mediterranean region who actually take this diet actually have less of incidence of hypertension and diabetes. So formula of the caloric requirement, what should be a caloric requirement per day? This is given by WHO, and I have highlighted only 30 to 60 years and over 60 years because the younger ones we don't need to highlight here. So age 30 to 60 years, 8.7 into the weight in kg plus 829. This is the caloric requirement of a normal person aged 30 to 60 years, a normal woman. And women aged above 60 years, 10.5 into weight in kg plus 596. And we should keep within this parameter. Physical activity, I really cannot emphasize enough because we all know that physical activity is very, very important. Especially you have to balance between the cardiorespiratory fitness, muscular strength, and endurance. Muscular training is very important to keep your muscles, sort of muscle volume good, and muscle volume good will always give strength to your bones. You can always do walking, whatever exercise you want to do. You can do yoga, and Tai Chi are very good for your, mental rest also. Both the things go hand in hand. Weight, the exercise and the food dietary restrictions. Drink in moderation. So nowadays, they say social drinking is okay, but smoking is absolutely no. These are the different lifestyle modifications that I have taken out according to your BMI, and they are both for the WHO parameters and the Indian parameters that you can see. Lifestyle modification is a mainstay of all the treatment modalities. Combined therapy will always work, and what about MHT? So MHT, as we know, if started at the right time and in the window of opportunity, always has a protective effect because it improves your insulin resistance. It has it's a protective factor for cardiovascular disease and lipid profile. And so definitely plays a good role, but that is not the treatment as such. It cannot be given for treatment of metabolic syndrome or to prevent metabolic syndrome. So coming to the conclusion, spread the word of awareness amongst everyone. So every patient who comes to you, spread the word of awareness, how, your weight is important, your exercise schedule is important, and how the diet that you take is important. Care should be started very early. In fact, prenatal. That is what fetal programming is all about. Lifestyle modifications should be started in childhood. We all started very late, but should be started in childhood so that you see so many children of type 1 diabetes and obesity. So it's very important to start early. Maintenance of an ideal BMI is very important. Intervention with insulin sensitizers and metabolic modulator drugs wherever required. And metabolic syndrome often complicates many physiological consequences of menopause, growing into a significant public health issue. And challenges to clinicians to adopt strategies for managing them is always open to us. More research is needed to understand the gene-environment interaction. And observe the discrepancy. Why the discrepancy between the Asians and Caucasians? So more research is required. Now, for the physician, we should look into the factors before the problem becomes a full-blown metabolic syndrome. Discuss the woman's risk profile and show accurate, she should have a proper focus actually in life, how she has to maintain her life and what her lifestyle should be, to develop a long-term effective community-based preventive health program of exercise, dietary modifications, behavioral therapy, and pharmacological interventions at the right times should be instituted. So life is beautiful, but don't let it be like this. Life should be like this. You should be in good health, should be exercising, and that's how you have a healthy, golden age. I always say 60 and above is the golden age, but it is golden only till the time you're healthy. Otherwise, it becomes a burden. Thank you so much for a patient hearing.
Thank you. Thank you, Dr. Pushpa. Given time, we will even talk a lot more about Met as we know. It was a very lucid talk. You stress the fact that prevention of Met starts right from in utero. Because the fetal programming and environment are very, very important. And I think even at adolescent healthcare is also equally important. And especially not the BMI, it is a waist circumference we have to focus more on. And I'm afraid many of the gynecologists 50 plus, how many of us are aware of our own waist circumference and how many of us take care to reduce the waist circumference? I'm really worried about it. What we preach, we should follow also. That is very, very important.
Thank you, Dr. Pushpa. She has narrated very nicely, and importantly, she has alarmed that 22% in menopause, the incidence, and 32 to 48 in menopause, post-menopause. And it's really alarming. And she has stressed on waist circumference, and mainly, rather than to take medicines and all those, diet and physical activity. This is very important. Thank you. Thank you so much, Dr. Pushpa.
Thank you
Very
so much.
important point which Dr. Pushpa you have mentioned. The two patients which we have may be having a all right BMI, but if their waist, hip and waist ratio is not good, then they are the people who should be caught. So that is very important.
Yes,
They may be having the right,
right weight, right BMI, but if the waist circumference, the hip waist ratio is altered and central obesity is there, they are actually candidates for metabolic syndrome.
Thank you. Thank you.
Thank you. Thank you very much.
Dr. Neelam has been there. Can we have our comments? Dr. Neelam?
Is she there?
Almost there.
Yeah, I can see her. Dr. Neelam Agarwal, ma'am? She's there, but she's there. Just her photo is there. Maybe we can go to the session 3.
Yes, session. Yes, ma'am. So moving on to the third session. I invite our chairpersons for the session. Dr. Priya Ora, who is the Managing Council member of MOGS and Vice President of Mumbai Menopause Society. Next, we have Dr. Vinita Singh, who is the Governing Council member of ICOG and also the past President of Partner Obstetric and Gynecological Society. And we have Dr. Ritu Sharma. We have three interesting talks in this session. The first being cervical cancer screening in midlife by Dr. Sarita Sham Sundar. Ma'am is chairperson of Oncology Committee of AOGD and the immediate past president of Indian Society of Colposcopy and Cervical Pathology. And she's also the editor of Journal of Colposcopy and Lower Genital Tract Pathology. Over to you, ma'am.
Thank you so much, Dr. Anju and the and ICOG for this invitation. I think this is an excellent academic activity on menopause with so many aspects being covered. All of us go through menopause, and this is a phase which, all of us have so many doubts about it. So then, with all those problems of menopause, also comes the problem of cancer. So also there is an increased risk of cancer in the peri and post menopause. So how do we go for about cervical cancer? What about cervical cancer, and how do we go about screening it? So cervical cancer remains a preventable malignancy with appropriate screening, and perimenopause brings hormonal, anatomic, and cytological changes that influence the screening accuracy and interpretation. So globally, there are 6 lakh new cases every year, and in India, about 1.2 lakhs every year, and more than half of them die because of the disease. The peak incidence in India is 50 to 59 years. This is the age which overlaps with the perimenopause. 95% of them are associated with high-risk HPV infection, and screening has reduced incidence and mortality significantly in developed countries, and it is really important for all of us to take it up. So the perimenopausal, consider what happens in peri and postmenopause. The hormonal decline causes the atrophic epithelium, and the cytological changes may mimic dysplasia. The cervix becomes smaller, the os becomes stenotic, so that leads to sampling challenges, and vaginal dryness may increase the discomfort during while you're going for testing. So you need to be sensitive and have a patient-centered approach. So then this is how the cervix looks at the time of menopause. You can see the cervix is small, flattened, and there is no glycogen. So the cervix looks pale. And because even after applying Lugol's iodine, you see, because there is no glycogen, and so the cervix appears, yellow even without any dysplasia. And then the epithelium is thin. You can see that just as soon as you put the speculum, the epithelium, because it's a thin epithelium, it starts bleeding, and you get these punctations and hemorrhagic spots even without any malignancy. So this, if you look at the anatomy of the uterine cervix, on the left side, you see this in the normal premenopausal state. You see the squamocolumnar junction here. But what happens in menopause, perimenopause, and menopause, the squamocolumnar junction shifts inside. So this squamocolumnar junction is inside the endocervical canal, and you don't see the squamocolumnar junction at all. So what is the basis now? What is the basis of the screening test, and how do we go about screening? So we know that the cervical cancer is caused by HPV. So it's basically because the entry of the virus, which enters at the time of sexual activity, it goes straight to the basal cells, stays outside the nucleus as this small ring of plasma, as a plasmid. So that is the HPV virus. Later on, it gets integrated into the nucleus of the cell, and then most of the women clear the infection on their own within 2 years. But if the infection persists, that's when the HPV gets integrated into the DNA of the cell. And that's when you get precancerous changes and then cancer. So at all these stages of HPV infection can be detected. So when the infection actually just starts, the HPV virus just enters, that's when you can detect as the HPV test. Then the precancerous changes happen. So that causes changes in the morphology of the cell, which you can detect by the pap smear. So either initially there will be mild changes, and then there will be severe changes, severe dysplasia, when there's increase in the size of the nucleus, and then cancer. So when there is just HPV infection, you detect by the HPV test. But when there are changes in the epithelium, that's when you can detect by the pap test and the VIA test. So the difference, so this is the basis of the screening method. So when there is HPV infection, as soon as there is HPV infection, you can detect by the HPV test. When there is persistent infection and then you get CIN, that's when you get VI positive, where the visual test and the pap smear or LBC will become positive. So this is the basis of these various tests that we have. Now coming to the pap test, what is important in the perimenopause is because the atrophy, it's better to use a smaller speculum and apply the lubricant sparingly. Consider topical estrogens for 7 to 10 days pre-test if it is atrophic. So if the cervix is atrophic, better to give some estrogens before you take the pap smear, and ensure sampling of the transformation zone. Use either the brush or the spatula. So that means we need to use, if you're using a conventional pap smear, use the brush along with it, along with the spatula which is provided. So use both. And if you're doing an LPC, then of course, then use the brush, and that's good enough. Then that will sample the endocervix also. And the label and transport properly for cytology and HPV analysis. So what about the interpretation of the pap smear? So cytology, we do get a lot different reports when we sample the postmenopausal women, especially because of their atrophic changes. The low estrogen levels cause thinning of the cervical lining, and these atrophic cells can be mistaken for precancerous or cancerous lesions, especially in the conventional smears. And so this can lead to misinterpretation and a false diagnosis of an abnormal smear, that is ascus, or abnormalities, then that can complicate management and potentially leading to unnecessary follow-up procedures. So this is like a menopausal smear in a woman who is post-menopause, and you can see the large sheets of parabasal cells, because the superficial cells, we know that that's a multi-layered epithelium, normally the squamous epithelium. So when there is less of the superficial layer, you get more of these parabasal cells, and there are some naked nuclei even without any cell. So this appears like a cell that is which has a big nucleus. So this is not a big nucleus. This is basically, these are the parabasal cells. Because normally the pap smear, you get the big cell and there's a small nucleus, but here you can see that most of the cells are having big nucleus. So this is misinterpreted as an abnormal pap smear. Again, because of vaginitis, because atrophic vaginitis, you get a lot of inflammatory smear. So you get all these inflammatory cells. You can see a lot of WBC there. And then a cluster of these parabasal squamous cells, and there's some which appears to be a slight nuclear atypia. And so this, again, this inflammation has to be treated before you go for taking a pap smear again. Again, this is the atrophic and inflammatory smear. You see a lot of WBC there, and there are pseudo parakeratotic cells and nuclear degenerated changes. And there is one cell with a large nucleus. So this appears like ASC-H, that is abnormal atypical squamous cells, very high grade. So all these changes can occur even without any dysplasia. So this atrophy can mimic HSIL or ASCUS, so that is false positive. So how can you what do we do? So we can give estrogens. So that will help the atrophic cells to mature, but the dysplastic cells will not respond. So the dysplastic cells will not change. So the epithelium becomes better and you will be able to see the epithelium. So this is if you give estrogens for 1 to 2 weeks, an atrophic epithelium becomes thicker, and then you'll be able to see it. But then you still will not be able to see the squamocolumnar junction because that is still inside. So if you do see any abnormal areas, then in that case, or the cervix appears unhealthy, or even after you giving estrogen, the pap smear is still abnormal. In that case, one needs to go for colposcopy. So what is the percentage of the Indian women who have normal smears, peri or post-menopause? So overall, it was found to be 2.4 to 8.2%. And there was a study carried out which actually categorizes that how many were abnormal. So 60% were atrophic, 23.8% were inflammatory. Ascus was found in 4.6%, LSIL in 2.3%, HSIL in 2.9%, and squamous cell carcinoma in 1.9%. Now, coming to the next screening test, that is visual inspection with acetic acid. Can we do it in peri and postmenopause? It is a simple test and something which can be done anywhere and everywhere with dilute acetic acid. But what are the challenges with VI? The squamous epithelium, again, because it's atrophic in postmenopausal women, and it appears pale white after applying acetic acid. So, as such, the cervix is atrophic, and even after applying acetic acid, the whole thing becomes pale. So, detection of acetowhite areas actually proves to be difficult on a background of pale atrophic epithelium. So, we need to examine carefully with particular attention to the real-time changes and delineation of margin of the acetowhite areas. And then the squamocolumnar junction is not visualized completely, and the lesions within the endocervical canal cannot be detected by VIA, and then because we are only seeing the ectocervix. So therefore, VIA is not recommended in peri and postmenopause. So this is how the cervix appears, even before applying acetic acid. So it's an atrophic cervix, and you can see because it's a thin epithelium, it bleeds easily also, and you see the vessels, the prominent vessels here, and you see there's hemorrhagic spots. And this is after applying acetic acid, we can see that there is an acetovite area. The blue arrow is pointing to that. It's a thin acetovite area and is covering most of the cervix on the posterior lip. So here this one has to see very carefully, and the rest of the cervix also is very pale. So we need to really look carefully to actually delineate this acetovite area. Then the squamocolumnar junction is not visible, so either it can be partially visible like this on the left side, or it may not be visible at all. So this is that's why VI cannot be done. It's not reliable in peri and postmenopause. Now coming to the test of today, that is the HPV test. Why should we be doing an HPV test for cervical screening? Because it's an objective test. It is cost effective in the sense because the screening interval can be delayed. It detects a high risk strain, so it's not dependent on somebody actually seeing like the pap smear or the VIA. And so it's an objective test, increased feasibility and acceptability. And so it picks up better, its sensitivity is better, and there is a possibility of self-sampling. And so it should be the screening modality of choice wherever possible. So the provider collected samples. So just like we are doing the LBC, the same brush can be used for taking the HPV test. So this is how you take the HPV test, and then in the self-sampling also can be done. This is possible with the HPV test, and while collecting the sample for HPV testing, so the woman should direct the swab in the same direction, that is upwards and backwards, while she is in a standing or a squatting position. And then self-collection devices are all available. They're all available in India. So this is the Copan brush, which is compatible with most of the machines. So coming to what is the types, what is the basis of these tests? So the commonly available test, one is the hybrid capture test, where basically the DNA is split into two. It is hybridized with the RNA, so you get the DNA RNA hybrids, and then you apply the monoclonal antibodies, and then a second monoclonal antibody is added to actually get these chemiluminescence. So the report you get is called, it's a relative light unit. So an RLU of, sorry. So an RLU of more than one indicates a positive test. So if you, in the sense, this hybrid capture is actually a quantitative test because it is positive when there are more than 5,000 viral copies. Now, the commonly used test, another commonly used test is the PCR. So that was the basis of our own COVID test, also the polymerase chain reaction, where the DNA strands are split into two and they are hybridized with the primers, and then they are amplified. So that's how you get with the HPV primers, and that's they're amplified, and you get if it is positive, that is detected. Now, TrueNat is another. It's an indigenous HPV test. Again, this was detected, this was actually validated with the standard test by ICMR and AIMS. So which test should be chosen? because there's so many tests available. So choose an HPV test that is clinically validated either by the FDA or the WHO or the ICMR. And a cost benefit analysis. Now these tests have an expiration date. So it's either they maybe 9 months or 12 months. So guidelines, so whatever HPV test you are using, should be tested against a standard. So it should have a clinical sensitivity of detecting CIN2 or more, at least the sensitivity of not less than 90% and specificity of at least 98% when it's compared with the hybrid capture. So these are the FDA approved tests. The BD by BD company, which makes the same company that makes the liquid-based cytology. So that the SurePath, so the BD on Clarity, then the Qiagen or the hybrid capture test. This is the oldest test which was FDA approved. Then you have the Hologic Eptima. This is an RNA test, and then you have the Roche Cobas. This is also an HPV DNA test. So these are another WHO pre-qualified test also. So that is the COBA. So that is the expert HPV. This is made by this company Safid, and this is made by the same. The Safid is the company which also makes the CBNAT. So that is the TB testing. So that is the expert HPV test, and we also have the Siemens test available, and the C-gene also is available in our country. Now coming to what is genotyping and what are the genotypes which are important for us. So if you look at, this is the information from India, from IARC, WHO IARC about the cancers and the CINs in India. So what are the HPV types associated? So if you look at cervical cancer, 60, not just 16, 18, even they have detected 45 HPV, 45, 33, 35, 58, and 31. And in high-grade CIN lesions, they have detected 16, 18, apart from 16, 18, 51, 53, 31, 58. And then low-grade lesions also have all these. So therefore, if you have genotyping available, it's good, but then there is a cost to it, to genotyping. So the BD has genotyping. There are 9 results in the primary run itself. In hybrid capture, doesn't give a genotype, but tells you all the high risk if it is positive. Now Roche tells you 3 results in the primary run, either it is 16, 18, and the other high risk types, and the Hologic 1 result in the primary run, and then the second tells you the others, and the Abbott 5 results in the primary run. So just in the primary run, you can know a few of the high risk types, and then or the secondary. So should we be doing HPV test alone or a co-test? Now, many people think that co-test is better, but it does not actually add clinical value especially among postmenopausal women, and may increase follow-up procedures and referrals, because you do get a lot of false positive results without detecting any additional clinically significant disease. Now, what are the guidelines for screening? Now, the WHO does recommend HPV as a preferred test for screening, because you can screen, the screening intervals can be 5 to 10 yearly, screen from 30 to 50 years, but this is provided you are doing the screening is happening regularly. But if the woman is coming at 50 years or more than that, if she's not had any screening, then you should go ahead and do the screening. So at least 2 negative screenings should be done before you say, okay, now screening is not required. So and for women living with HIV, it start earlier, 25 to 50 years. So HPV test is not available, then it is the PAP test or the VI, but at perimenopause, again, VI is not very reliable. So the FOXY screening recommendations, we start at 25, end at 65, but with 3 consecutive negative cytology results or 2 consecutive negative HPV results within the last 10 years. So the most recent test should have been performed within 5 years. So the screening interval with HPV is 5 to 10 years, and with cytology is 3 years, and VI is 3 to 5 years. Now, screening after hysterectomy is not recommended, but if it was done and there was CIN, then in that case, screening is to be continued. So what next after a screening test? So anything more than, if the PAP test shows ascus or anything more than that, then if it's ascus only, then reflex HPV testing can be done if possible. And if it is positive, then go for colposcopy. But if it is negative, then repeat after a year. But anything which is, if it's LSIL, HSIL, it's an indication for colposcopy or even ASCH or abnormal glandular cells. All these are indications for colposcopy. HPV 16-18 direct colposcopy. No, HPV non 16-18. One option is to go for PAP, and if the PAP is abnormal, go for colposcopy. The other option is go for colposcopy straight away, because as I've shown you, there are cervical cancer is seen in India, even with the other non-16-18 also. But if it's a negative HPV, then one can go for routine screening after 5 years. So in summary, the peak age of presentation of carcinoma cervix is 50 plus years in our country, and the peri and post-menopause causes changes in the cervix and the epithelium. The PAP is unreliable, the false positivity is high. And VI is unreliable because you cannot see the squamocolumnar junction. When the HPV is the reliable test, sensitive and specific. But if you going ahead only with the PAP smear, then if we find anything more than ascus on PAP and for HPV positive, one needs to go for colposcopy and biopsy. So thank you so much. And with this, I invite you for the Star Sampurna Foxy Presidential Conference, which is happening in Pune on from 14th to 16th of November. And there are 10 workshops, pre-Congress workshops, and a lot of interesting sessions to look for. And then, of course, the ICOG, the big Mega Foxy Conference in Delhi from 14th to 18th of January. And the deadline for early bird registration is just tomorrow, and for abstract submission. So please hurry up and do your registrations. And of course, the World Congress of Colposcopy, if you're interested, in Paris, that is 4th to 6th June 2026. Thank you so much once again to the entire ICOG for this invitation.
Thank you so much, ma'am, for such an elaborate talk. Priya, ma'am, Dr. Priya Vora, ma'am, are you there? For your comments, ma'am? You're muted, ma'am. Priya, ma'am, you're muted.
Hello. Yeah. Am I audible? I
Yes,
think
ma'am.
it was an
Yes.
excellent presentation, madam, with
Thank
all
you.
your latest tests and the techniques, right from the guidelines. I think it was wonderful.
Thank you,
Yeah.
ma'am. Thank you.
It was a pleasure listening. Yeah.
Thank you.
Thank you, ma'am. Now moving on to our next talk. We have Dr. Charu Bapai, ma'am, with us. Ma'am is the chairperson of the Breast and Puerperal Health Committee of Foxy, and she's also the director of GEMS Hospital Endoscopy Center at Pune. Over to you, ma'am.
Thank you so much. Indeed, a pleasure to be here for this ICOG course. And I really thank Dr. Parag Beniwale, Dr. Sarita Bharerao, and of course, the conveners of this particular program, Dr. Anju Soni, Dr. Archana Dwivedi, and Dr. Rajendra for this opportunity. Dr. Priya, pleasure seeing you here, though virtually. And I will be sharing my screen.
Yes.
Is my screen visible?
Yes, ma'am.
All right. So my talk for today is essential screening tools for breast cancer. Usually we start with a show of hands. As to anyone here today in this audience who knows a family member, a friend, a relative, or a neighbor who has suffered from breast cancer. I think all our hands will go up essentially because we are all aware that today breast cancer is the leading cancer amongst women, not only in the West, but also in India. Not only in urban India, but it is definitely growing in rural India as well. Let us talk a little bit about the Indian scenario regarding breast cancer. As we just discussed, it has already overtaken cervical cancer as the number one cancer. 1 out of every 28 women in India will develop breast cancer during their lifetime. In India, the average age of high risk group is younger, 43 to 46, as compared to the West, where it is 53 to 57 years. So it is our perimenopausal women who are going to be, initially be presenting. And of course, the postmenopausal women are definitely going to be at a risk for developing breast cancer. What is different in the Indian scenario as compared to the West? Well, in the West, most cancers are detected at stage 1 and early stage 2. In India, however, most cases are detected at stage 2B and beyond, which translates into more radical surgeries, more toxic adjuvants, and more deaths. The 5-year survival rate was 56% among patients diagnosed with breast cancer at a later stage in comparison to 85% for cases diagnosed early. Hence, the need for screening for breast cancer. The objective of today's talks are to identify the screening methods that can be used for early diagnosis of breast cancer, see how they can be implemented in the Indian scenario, prove the benefits of early diagnosis, and discuss how the breast can be conserved. The essential components of breast cancer screening are cancer prevention, the breast screening, and of course, genetic screening. What does my kitty contain today? We talk about breast awareness, self-breast examination, clinical breast examination, and the different screening techniques. Ensuring availability of early diagnostic and screening services and taking immediate steps have been regarded as the two main strategies for warranting improvement in the prognostic outcome. Make your patients breast aware. Teach your brain and train your hands. Make them breast aware. Teach them the commonest symptoms of breast cancer. Train her hands to understand her normal breast tissue so that she at once knows when something is not normal. Do not be afraid, be alert and be aware. This is the message that we wish to give each and every woman of our country so that she at once understands a change in her breast size, shape or texture. What about self-breast examination? I think all of us are very aware about this, but just for a revision, we are going to talk about it. It needs to be done once a month, immediately after the menses in women who are menstruating, and for those who are menopausal, then it can be done on any fixed day of the month. It has to be done on both the sides with the middle portion of the fingers. Feel for the marble in the bag of rice. Do not forget the tail of the breast. Check for nipple discharge. It can be done in the lying down position or in the standing up position. Usually we advise the women to do it in the shower or immediately after a shower and standing in front of the mirror, because at that time the skin is moist, and if there is a lump in the breast, it is going to slip under your fingers. But what do studies say? Well, studies say that there is insufficient evidence that breast self-examination is effective in reducing mortality from breast cancer. And so in many countries, it is only becoming breast aware, which is mentioned, and self-breast examination is not a part of the breast screening process. But however, in a country like India, where even talking about the breast is taboo, leave alone touching the breast, I think it is essential for us to let our women know that they need to take a look at their breast, they need to touch their breast, and they need to find any changes in the breast. And so in a country like India, where mammography and regular physical examinations of the breast are not practicable as public health policies, self-breast examination definitely needs to be done. Become breast aware. Love your breasts. Touch, look, and check is what we advise our women. Now coming to clinical breast examination. We, as a part of the Breast and Puerperal Health Committee of FOXY, will advise each and every gynecologist to make sure that any woman entering your clinic needs to undergo a clinical breast examination, irrespective of the fact as to what symptoms she has come for. I had the good fortune of conducting the Swasthanari Abhiyan Yatra, in which I traveled from Kashmir to Kanyakumari, and it gives me immense pleasure to say that Kerala is the one state where the government has also taken immense efforts for early diagnosis of breast cancer, and as a result of which, over there, every gynecologist definitely checks the breasts of all the patients entering their clinic. I think it needs to be made as a country-based mandate, wherein a radial approach, a concentric circle approach, or a checking by vertical strips method is done for a woman entering your clinic for the clinical breast examination. For this, the woman needs to be stripped waist upwards. She needs to be having her privacy. Again, it can be done in the sitting position or in the lying down position. The checking has to be done right from the clavicle until the under border of the breast, and from the mediastinum right up to the axilla. Only then will we be able to do a thorough examination and diagnose a problem in time. What do studies have to say? This is really a fantastic study by Dr. C.S. Pramesh and Dr. Badwe from Tata Memorial Hospital, Mumbai. And in 2021, they came up with these results indicating that clinical breast examination conducted every 2 years by primary health workers significantly downstaged breast cancer at diagnosis and led to a non-significant 15% reduction in breast cancer mortality overall, but a significant reduction of nearly 30% in mortality in women aged beyond 50 years. And so, friends, it is very, very necessary that clinical breast examination becomes an important tool in our armamentarium for early diagnosis of breast cancer. Another important point that I wish to mention that it can be done by any primary health worker. So you in your busy OPDs need not, spend time doing the clinical breast examination if you think you're over busy. Any person in your clinic you can train to perform the clinical breast examination, and that too is going to be very useful. And now coming to the imaging techniques. Who sees the human face correctly? The photographer, the mirror, or the painter? Asked Pablo Picasso. And we ask, who sees the breast correctly? Ultrasound, mammography, MRI, or something else? Let us come to the basics, where we discuss about the breast anatomy. The breast is divided into 15 to 20 lobes by septae. Each lobe consists of fibrofatty tissue and glandular tissue, and a lactiferous duct lined by cubical epithelium is going to drain the lobule. The cancer is going to arise either from this duct or from this glandular tissue. And so we're going to image the breast either with ultrasound, mammography, thermography, MRI, electrical impedance techniques, or nuclear medicine techniques. Mammography. Whenever we talk about the breast, it is only and only mammography. And currently, mammography is the gold standard method to detect early stage breast cancer before the lesion becomes clinically palpable. So now when we say the screening methods for breast cancer, that means that there is nothing wrong with the lady. So your patient may ask that if you have not felt anything to your hand or when you've done a clinical breast examination, why are you subjecting me to a mammography? We need to let her know that mammography is going to detect the lesion before it is going to become clinically palpable, and it is going to help to reduce the mortality rate by 25 to 30% in screened women when compared with the control group after 5 years. Randomized trials of mammographic screening undoubtedly have shown that early diagnosis is 100% possible and treatment of breast cancer is going to be done early, which is going to reduce mortality because of breast cancer. So we need to understand that it is a screening and diagnostic tool. It is the standard of care for any clinical abnormality along with as well as it is the most important modality for screening purpose. When we talk about mammography, there are so many different kinds of mammographies which are available, like the screening mammography, the diagnostic mammography, the digital tomosynthesis mammography, in which the basic technique has been modified to acquire 3D views of the breast, which is really fantastic, available in so many major cities, and I think it really reads the breast as nobody else can. There are various variations like ductography, which can be used in abnormal nipple discharge. And of course, and another variation, which is the contrast enhanced digital mammography, which can be used when the breast is very dense. When we talk about mammography, it is necessary that we talk about BI-RADS, wherein you have to score what you can see on the mammography, which is scored from BI-RADS 0 to BI-RADS 6. BI-RADS 0 does not mean that all is well. You have to call her back for an additional examination. BI-RADS 1, there is no problem whatsoever and routine screening can be carried out. BI-RADS 2 shows a benign problem like a small fibroadenoma or a small cyst, and this patient too can undergo a routine screening. BI-RADS 3 says it is probably benign, where there is a small risk of breast cancer, and these are the patients where you might call her more frequently for a screening procedure. BI-RADS 4 and 5 are antennae are going to go up and we are going to suspect malignancy, and BI-RADS 6 is known or a biopsy proven case of breast cancer. Along with BI-RADS 0 to 6, we also see the BI-RADS has A, B, C, and D as divisions, where BI-RADS A is a fatty breast, which is a postmenopausal breast usually, wherein a lump can be easily seen. But unfortunately, look at the BI-RADS D kind of a breast, which is extremely dense. Here, a small lesion is going to hide behind this extremely dense breast, and we are going to require additional imaging in such dense breasts. And so what do the American Cancer Society guidelines say? That age 40 to 44, There's an option to begin annual screening. But as we said in India, since breast cancer occurs at a younger age, we might as well start the annual screening. Age 45 to 54, an annual screening has been recommended. 55 years and older, screening can be done every 2 years with an option to screen annually, and discontinue screening when life expectancy is less than 10 years. Do the mammography post-menstrually. Tell your patient that the radiation is very negligible and she does not have to worry about that. What about ultrasound as a screening tool? Well, studies have shown that ultrasound screening in asymptomatic women causes unacceptable false positive and false negative outcomes, and so it is unacceptable for breast cancer screening in women who have no problem at all. However, it can be used as an adjunct to mammography in the assessment of both palpable and impalpable breast abnormalities, and it is the best imaging modality in the younger age group and in women with dense breasts and in pregnant and lactating mothers.
You have already crossed your time.
Yes, I shall wind up.
Few seconds left out.
I thought the earlier speaker got 5 minutes more, and so I was wanting to discuss a few things. But if time is not available,
we are too late.
That
Have wrapped by 7, but
MRI is going to be the tool which is to be used for high-risk patients. And we have good guidelines for breast cancer screening, where self-breast examination, clinical breast examination, mammography, and MRI have been mentioned. And when do we offer genetic screening? Well, we offer genetic screening to patients who are high-risk individuals who have a personal or a family history of breast or ovarian cancers at a younger age, less than 50 years, which suggests inherited cancer susceptibility should be offered genetic screening, or those who have got 2 primary breast cancers, or there is breast, colorectal, or endometrial cancer diagnosed before the age of 50 years. These are the patients where genetic counseling has to be offered for BRCA1 and BRCA2 mutations. The FOXI also has their recommendations for breast cancer screening. Women at average risk for breast cancer should begin annual mammograms at the age of 40. If a woman is between 25 and 39 years old, they should have a clinical breast examination every 1 to 3 years. High-risk women, clinical breast examination are a key part of the evaluation process, potentially alongside with other screening methods like the MRI. The screening frequency, mammograms may be performed every 1 to 2 years for women over 40 years, and screening should continue as long as women are in good health. Prevention is any day better than cure, so you should never lose the chance of counseling your patients about the need to maintain an adequate weight, a good diet, and a physical activity about which a lot has already been spoken, and that is going to prevent not only breast cancer, but all forms of cancer. And so, in conclusion, mammography is the screening modality of choice for detection of breast cancer. If possible, all women should avail the benefit of a 3D mammogram. Ultrasound is the modality of choice in young women or pregnant and lactating women. Always keep a high level of suspicion of pregnancy-associated breast cancer. MR imaging is to be used for a specific subset. Byrod's assessment criteria should be acted upon, and a stitch-in time saves 9. As we say, that clinical breast examination, mammography, and self-breast examination are the 3 pillars of screening for breast cancer. MRI to be used in high-risk patients. Friends, the gynecologist is the first point of contact for most women, and we must be well-versed with handling breast health issues. Thank you so much for a patient hearing. Thank you for the opportunity. Thank you so much, Dr. Anju, for the opportunity. Thank you. Pardesi sir, a very happy birthday to you. Pleasure sharing screen space with you on your birthday.
Thank you, sir. Happy birthday, sir.
Thank you so much. Thank you. It was nice talk, Dr. Charu.
Thank you so much, sir. Thank you. The pleasure is mine. Thank you.
Aditi, are you inviting Dr. Mala? Welcome, Dr. Mala, for the very, very important talk, obesity and cancer.
Good evening, everyone. It's my pleasure and privilege to be a part of this ICOG conclave. Obesity has emerged as one of the most important public health challenges worldwide. Once considered a problem of high-income countries, now it is rapidly occurring in the developing nations due to urbanization, sedentary lifestyle, and unhealthy dietary patterns. According to WHO, more than 650 million adults are obese globally, and the prevalence has nearly tripled since 1975. It's not, yeah. So obesity and cancer, there are three factors mainly: insulin resistance, chronic inflammation, and hormonal imbalance. Beyond these metabolic and cardiovascular problems, obesity is recognized as a significant risk factor for several cancers. The link between obesity and cancer is complex and multifactorial. Adipose tissue functions as an active reproductive organ, producing hormones, growth factors, inflammatory cytokines that affect cellular growth and proliferation. There is chronic low-grade inflammation, insulin resistance, increased insulin-like growth factor, and excess estrogens from adipose tissue, which collectively create a pro-carcinogenic environment. And that is why obesity has become modifiable risk factor for most of the cancers. In 2022, 1 in 8 people globally were living with obesity. Among adults, 43% were overweight and 16% were obese. The number of adults with obesity increased from 195 million in 1990 to 880 million in 2022. So that is the burden. And for children and adolescents, obesity rose from 2% to 8% in 2022. And what about India? According to NFHS, among Indian adults, 6.4% of women are obese and 4% of men are obese. Overweight, obesity combined among adults, 24% of women and men in India. And among children under 5, overweight rose from 2% to 3.4% in 2019 to 2021. Among adolescent girls, 5.4% is obese and boys 6.6%. So that is the burden. We all know obesity is defined as an abnormal or excessive accumulation of weight, and it is measured in BMI. So these are the ideal BMI, which has been decided by the WHO. But Asian population, health risk occurs at lower BMI values. Overweight more than 23 kilogram per square meter, and obesity more than 25 kilogram per square meter. And central obesity is especially important, which is defined by waist circumference more than 90 centimeter in men and more than 80 centimeter among women. So there is a strong association between obesity and increasing cancer incidence and mortality. WHO and IRC has identified 13 cancers clearly linked to obesity: breast, endometrial, colorectal, esophageal, adenocarcinoma, pancreatic, liver, and kidney cancers. And 40% of all cancers are related directly or indirectly to excess body weight. Cancer risk increases proportionately with BMI. And if you're lowering the weight, it lowers the risk of some associated cancer. So how obesity leads to cancer is due to the effect of the estrogen, insulin growth factors, and inflammation. The metabolic, hormonal, and inflammatory alteration. Obesity leads to insulin resistance, hyperinsulinemia, which has mitogenic and anti-apoptogenic effect. And this leads to quite a few of the cancers. So there is a chronic low-grade inflammation because adipose tissue acts as an active endocrine organ, secreting tumor necrotic factor alpha, interleukin, and C-reactive protein. These mediators promote oxidative stress, DNA damage, angiogenesis, transforming tumor microenvironment, malignant transformation. Sex hormone imbalances there in obese individual, in postmenopausal women. Lot of estrogen is made in the adipose tissue, and this leads to endometrial and breast cancer, especially in the postmenopausal women. There is adipokine dysregulation. There is an effect of adipolectin, adipokines, leptin, which all leads to the effect so that there is an increased carcinogenic and imbalance between these adipokines supports a pro-tumorogenic state. Oxidative stress and DNA damage, increased fat deposition and metabolic overload produce reactive oxygen species, leading to oxidative damage of DNA and proteins. There is altered gut microbiome, which influences acid metabolism and systemic inflammation. These changes increases exposure to carcinogenic metabolism, promoting colorectal and hepatic carcinogen. So this is the chain. Biological substrate of cancer in the obese, obesity is a risk factor, prognostic factor, risk for second cancers, impact on treatment delivery and toxicity, impact on quality of life, and of course, there is a financial burden. So obesity in site-specific cancers. So in endometrial cancer, one is the strongest obesity-related cancer. Excess adipose tissue increases peripheral conversion of androgens to estrogens, and there is unopposed estrogen exposure, which is risk increases 2 to 3 times in obese women, and morbid obesity, the risk increases nearly 7-fold of endometrial cancer. Breast cancer, especially in postmenopausal women, there's increased estrogen and reduced sex hormone binding globulin, which elevates and stimulates estrogen receptor positive breast cancer growth. And it is also related to poorer prognosis, higher recurrence, and lower survival. Colorectal cancer, especially the central obesity, which leads to hyperinsulinemia, elevated IGF-1, chronic inflammation, and alters gut microbiome, which leads to weight gain, physical inactivity, and these are the independent risk factors. Esophageal adenocarcinoma, especially because of the gastroesophageal reflux disease and Barrett's estrogen, both are which common in obesity. Visceral fat increases intra-abdominal pressure, promoting chronic mucosal damage. Pancreatic cancer, chronic hyperinsulinemia, and inflammation enhances pancreatic epithelial proliferation. Obesity is linked to both increased risk and poorer survival in pancreatic cancer patients. Again, obesity leads to non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, which can advance to hepatocellular carcinoma. Kidney also, obesity increases risk via chronic inflammation, hormonal changes, and adipokine signaling. Each 5 kilogram per meter square increase in BMI raises renal cell carcinoma risk by 25 to 30%. Again, in ovarian cancer, obesity is associated with increased risk of endometrioid and low-grade ovarian cancer. Mechanism includes the same: estrogen excess, insulin resistance, and inflammation. So this is, in short, tells you the cancer type and proposed mechanism, how obesity and site-specific cancers are interrelated. So obesity not only increases cancer risk, but also worsens prognosis. Patient often presents with more advanced or aggressive disease, insulin resistance, chronic inflammation, elevated estrogen promote tumor progresses and metastasis. Obesity is associated with reduced overall and cancer-specific treatment across multiple cancer types. As I've already told, each 5 kilogram per meter square rise in BMI increases cancer mortality by 10 to 15%. And treatment response, altered drug metabolism, underdosing, reduced chemotherapy effect. Radiotherapy may be less precise due to body habitus. Post-treatment complication, higher risk of infection, wound issues, thromboembolism, lymphedema. There is recurrence in mortality, greater recurrence, especially in breast and endometrial cancer. But positive impact of weight control, if there is weight reduction, exercise, dietary change, it overall improves the survival and better quality of life. So how can we prevent and intervene strategies? Primary prevention, reducing cancer risk by maintaining healthy weight. BMI less than 25 kilogram per square meter through balanced diet and regular exercise. More than 150 minutes walk per week of moderate activity lowers risk of breast, colon, and endometrial cancer. Diet, high in fruits, vegetables, whole grains, and fiber. limit red processed meat, sugary food, and saturated fats, avoid alcohol and tobacco, both synergize with obesity to increase cancer risk. And of course, there's public health measures, community programs promoting nutrition, physical activity, and obesity prevention. Secondary and tertiary prevention after diagnosis. Weight management during treatment also prevents further weight gain, supervised weight loss by improving the outcome. Exercise and rehabilitation enhances immune function, reduces fatigue, improves therapy. Treatment, counseling, nutritional counseling, personalized meal planning to maintain lean mass and control insulin resistance. Of course, it is a multidisciplinary support, collaboration between oncologist, dietitian, and physiotherapist. Long-term follow-up, monitor weight, metabolic health, and recurrence risk regularly. So to conclude, obesity has emerged as a global epidemic and a critical determinant of cancer risk and outcomes. It acts as a biological driver of carcinogenesis through multiple interconnected pathways involving insulin resistance, chronic inflammation, oxidative stress, and altered sex hormone metabolism. Evidence consistently show that excess adiposity increases at least 13 cancer types. Important is breast, endometrial, pancreatic, colon, and liver cancers. Beyond incidence, obesity negatively influences cancer prognosis, therapeutic response, recurrence rates, overall survival, and it is a double-edged threat, both a cause and a prognostic factor. Burden of obesity-related cancers is rising, especially in developing countries which are undergoing rapid urbanization and lifestyle transition. Addressing obesity through comprehensive prevention and management strategies, focusing on nutrition, physical, behavioral change, and supportive policy frameworks can significantly reduce the global cancer burden. Integration of weight management into cancer care improves quality of life, reduces recurrence, and enhances treatment outcome. So key takeaways: obesity influences chronic inflammation, hormonal imbalance, tumor promotion, associated with breast, endometrial, colorectal, pancreatic, liver, and kidney cancers, leads to poorer treatment response and higher recurrence. Lifestyle interventions lower risk and enhance survival. Prevention through early education, policy, healthcare, integration is essential. And we all have to tell our patients to maintain a adequate or ideal weight, which is the cause for so many health problems, including cancers. Thank you, Dr. Anju, for the opportunity. And it has been my pleasure to be a part of your ICOG program.
Thank you, ma'am, for a nice and elaborative talk and finishing well in time. So I would request Dr. Priya Vora Thakur for her expert comments on the talk. Madam is not there, I think. Dr. Priya? So I would request Soni ma'am to please say a few words. Ma'am, you have to unmute yourself.
Thank you, Dr. Mala, for such an enlightening, concise, presentation. Can we go for the pre-test, please, Aditi? Dr. Aditi?
I would request ICOG team to please put the post-test.
Yeah. Nilima, please put the post-test. Yes.
Yes, ma'am.
Yeah, please. Thanks, dear.
So you all can join on the link and start the test. The timer, have you displayed?
Timer is on.
Yeah.
Yeah. Gauri, share the scan code also.
Yeah.
दरवाजा खुल रहा है
Aditi, how are you? How is your hand?
Ma'am, it is better. Yeah,
Sorry
still
for
in the
this.
sling. How are you, ma'am?
Good, good.
Good. Nice to see you.
So you have removed the bandage, everything.
No, no, ma'am, it is still there. I have to go for my
Oh,
follow-up. Yeah.
okay, okay, okay. Take care.
How much time left, Aditi?
4 minutes are left.
आज डिस्प्ले नहीं हो रहा है कल डिस्प्ले हो रहा था
5 minutes, 4.10 sec. 4 minutes, 4 minutes around.
Okay.
Ma'am, somebody was asking about yesterday's test. It is not possible now, to share the link?
Yesterday's test was yesterday's topics also that Nilima, you can answer that if they want, but now they will not get the link. That day is done. So 3 days we have got 3 sets of different questions. So yesterday was yesterday topics pertaining question answers. So all 3 days actually attendance is compulsory. That's why that.
Dr. Sneha, you're asking for the link. I've shared it, but only 2 minutes are left almost, 2.5 minutes.
No, don't worry. There's a query in the chat box. If you had submitted within time, I think there is no question. It was not accepted. It must have been accepted. ICOJ team, just see in the chat box. Who was the name? I just. Anubha Singh, she has a query that she submitted yesterday but not accepted. Anubha, we'll come back to you. You're joining tomorrow also, obviously. So we'll come back to you tomorrow. Certificate will reach you within a month, Dr. Manju, and everybody else, so don't worry about that. We are keeping the record.
Last 20 seconds left, I think. Yeah.
I think we're done.
So,
Nilima, time up?
Yeah, time is up.
Yeah, okay. Thank you so much. I think everybody has submitted till now because after that they will not accept. Aditi, you'll read out the answers. Madam is also here. Anju ma'am is there.
But they'll
We'll
have to
display. We'll display. Just a moment.
Many of them are sharing their numbers also.
Yeah, how come I think it is explaining
Self-evaluation.
or is it doing itself?
Okay, so we are now declaring the answers. So kindly just see that. Aditi, you'll do the.
Yes. Which tool is considered the gold standard for measuring bone mineral density? DEXA. Answer is B, DEXA. What is the WHO definition of osteoporosis? The answer is B, low bone mass and microarchitectural deterioration of bone tissue. Question number 3, which of the following is not a secondary cause of osteoporosis? Answer is C, aging. Which of the following mechanisms best explains the link between obesity and cancer? Question number 4, answer is B. Question number 5, obesity is associated with increased risk of which of the following cancer? Answer A, breast and endometrial cancers. What happens to a woman's risk of cardiovascular disease after menopause? It increases significantly. Answer C. Which of the following lipid profile changes is commonly seen in postmenopausal women? Nilima, you have to move it up. Yeah. So it is increased HDL and decreased LDL. Answer is B. Which of the following best describes the basic pathophysiologic mechanism of osteoporosis? Question number 8. Answer is C. Imbalance between bone resorption and bone formation leading to a net bone loss. Which of the following is the most common site of osteoporotic fractures? Answer is B. Vertebra. Postmenopausal osteoporosis is primarily due to, Nilima, could you move the screen? Answer is C. Estrogen deficiency leading to enhanced osteoclastic activity. Next question. Question number 11. Which of the following is a non-modifiable risk factor for osteoporosis? Answer is D. Advanced age. What is metabolic syndrome? Question number 12. Answer is 4. It is a combination of interconnected physiological, biochemical, clinical, and metabolic factors. Question number 13. Which of the following is not a risk factor for metabolic syndrome? Answer is C. A healthy lifestyle. Question number 14. Metabolic syndrome increases the risk of, answer is 1. Cardiovascular disease. Question number 15. Which is the primary purpose of cervical screening? It is to prevent cervical cancer by identifying early changes. Answer is B. Question number 16. What is the recommended age to start cervical cancer screening by WHO and FOXI guidelines? Answer is C. 25 years. Question number 17. Select the false statement. Answer is C. Lamellar bone is weaker than woven bone. WHO is 30 years, they are writing in the question number 16. Ashna ma'am, see to it later. 16. Then question number 18. Select the true statement. Answer is B. Osteocytes have a mechanosensory function. Question number 19. What is the average age of high-risk group in India for breast cancer? Correct answer is A. 43 to 46 years. And the last question, what are the components of breast cancer screening? It is D, all of the above. So these are the answers, and there was some discrepancy in question number 16. Somebody else. So now I invite Anju Soni ma'am for the vote of thanks.
So before Madam starts, I think it was a very fruitful session and very, very nicely compiled. Anju ma'am, thoroughly enjoyed learning experience, revisiting, and so very well curated topics. As usual, we are fans when it comes to academics when you're doing so. So thank you, ma'am, for this knowledgeable session. And there were discrepancy in one question yesterday, question number 18 and question number 16 today. So that probably we'll look into the matter and revert back to the audience by tomorrow. So I would request Anju Soni madam to wrap up the session. Thank you so much.
Thank you, Dr. Archana. I give my heartfelt gratitude to all the eminent speakers, chairpersons, and delegates for making day 2 of FOXI ICG certificate course truly insightful and inspiring. We deeply appreciate the enthusiastic participation and keen interest shown by all the attendees, which made today's session on bone health, metabolic health, wellness, cardiac health, cancer, and screening truly engaging and impactful. Together, we continue our shared mission to women health through knowledge, compassion, and evidence-based medicine. And I'm truly thank ICOG, FOXI, Dr. Sunita Tandulkar, Dr. Swarna Khadilkar, ICOG team, Dr. Parag Vinewale, Professor Ashok Kumar, Dr. Sarita Valero, incoming chair, Dr. Sheila Mani, for giving us a free hand and for today's session. And I thank all of them once again. And I thank all of you also for being here. And I'm sure that tomorrow's session also you will enjoy. So looking forward to tomorrow's session. And all of us need to come together, and I'm sure it is our mission to help all the women of our country past their perimenopause and menopause. Thank you, everyone. Good evening, good night. See you all tomorrow.
Yeah, thank you, ma'am. Thank you. Good night, everybody. Good night, Jawar sir. Bye bye.
Good night, Jawar sir.
Raju sir is also here. Hi, sir. So I think we'll leave now. Everybody, good night. Have a good dinner time ahead. Thank you so much.
Good night.
Sarita ma'am has conveyed her best wishes to everybody. She's into some emergency, so couldn't join at the last moment. Thank you so much. Bye bye.
And thank you and bye bye.